And today, we're going to discuss this phenomenon. We will discuss it from several viewpoints, from the standpoint of science, from the standpoint of clinic and laboratory. And after that, we will sum up the results, where we are and where we're going. Good morning, colleagues. It's my pleasure to introduce our first speaker, Alexey Viktorovich Tataryan, and he will speak on the following subject: antimicrobial resistance, scientific and practical development of this problem. Could you please switch on my slides? Next slide, please. Unfortunately, we do not have clickers here, so I will have to tell you when to switch the slides. And I would like to speak about contaminant conditions. And you see that WHO General Secretary in 2019 said that all countries should find a balance between the access to the essential antibiotics and prevention of antimicrobial resistance. According to CDC, every year about 50 million courses of antibiotics are introduced in the USA in cases when it's not really necessary, and you understand that in other countries it is no better. Next slide, please. In the Russian Federation, antimicrobial resistance monitoring is on. This system is quite efficient. These are laboratory service in medical institutions, epidemiological departments of Russian Watchdog for Consumer Protection in Russian regions, monitoring of isolates from environmental sites. From food. It also includes veterinary monitoring of microorganisms. And of course, research is conducted by various institutions, all types of institutions. Now, I would like to develop on the system of monitoring over antimicrobial resistance of the Russian Watchdog for Consumer Protection. We have two reference centers. They are based in the Central Research Institute of Epidemiology of Russian Watchdog for Consumer Protection, and they are engaged in preventing resistance to antibiotics in food industry and in medical institutions. This is a very important area indeed. So it's like a hidden part of the iceberg that actually shows why this problem is so important. So this is the information taken from Reference Center on Food Products, and here you can see the sources of microorganisms with antimicrobial resistance. You can see that we have had similar situation over the last 3 years. First of all, these are poultry products and meat. So you see that in 2020, half of such agents were found in poultry products. The structure of resistant microorganisms detected in food products. So actually over the last 3 years, the structure hasn't changed. Salmonella is in the first place. It is followed by Staphylococcus aureus. And last year, Staphylococcus aureus decreased a bit, However, the stevia monocytogenes grew significantly. These are the data on medical institutions. These are the data of reference center. They show the structure of resistant flora. And they show that actually this structure is preserved. The dominant role is played by escape pathogens. And speaking about resistant strains, here you can see the distribution of them. 51.5% is ESBL, and MDR is also quite disseminated. 1/4 of the strains had multi-drug resistance. It shows that the problem of resistant strains dissemination is really important. What can we do about it? Well, of course, we will try to develop new antimicrobial drugs, but you can see that it's quite difficult to do it. "222 drugs are being developed in the world. This work is in process, and their efficiency and safety should be proven. According to optimistic scenario, by 2030, 2 or 3 of these drugs will be registered. So the academic community decided to look for various substances that could influence resistance. You know that there is internal or natural resistance. And all of us are well aware of acquired resistance. These are resistance genes. And actually everyone can detect it. And there is also adaptive resistance or transit resistance, tolerogenic resistance. There are a lot of names for it, and this is one and the same phenomenon. It shows that this phenomenon hasn't been well studied yet. And we have a lot of work ahead of us in this area. This is the transit resistance. It has been known for many dozens of years. You know that this experiment was conducted more than 120 years ago. This is a sample of water. So it is taken, and under the microscope you can see a lot of microorganisms. And nothing grows in battery plate. These are bacteria that cannot be cultivated. And they are the carriers of this transitory resistance. These tolerant or persister cells, you can see them in the middle, they have a unique capacity to be transformed into active vegetative forms, or they can also be transformed into anabiotic forms that can exist for millions of years in soil. These are VBNC cells. And what molecular stimuli can initiate them? Actually, it will determine the way they will develop. The control of this non-cultivated form generation has been well studied. You can see that there are a lot of various substances. that can regulate this adaptive resistance of microorganisms. In particular, we're engaged in studying alkyloxybenzols, and this is our reference center. Actually, it is involved in this work, and we have found that when we add such a substance, in particular hexylresorcinol, but that's not actually important, there are dozens of them and hundreds of them. This is just something that we started because it was registered. It was registered as a medicinal product. So the antibiotic was registered as a medicinal product, and this substance was registered as well. So here there are 2 registered substances, and in principle it's more convenient for practical use compared with the situation when one of them were not registered. When it is added to strains, for example isolates of gram-positive bacteria, these are Staphylococcus aureus, for example, and I'd like to stress that minimum inhibiting concentration of antibiotics, actually when this hexylresorcin is added, this concentration is decreased by 128 times. It means that antibiotics can be used in a lower concentration. Speaking about gram-negative microorganisms, that is the same. So when we use ciprofloxacin, we see that Pseudomonas aeruginosa minimum concentration is 50 times decreased. These are in vitro data. So the speed of Klebsiella death grows as well when we use polymyxin, and you can see clear dose-dependent death when polymyxin is used. And when we add polymyxin to the minimum concentration, when we add hexylresorcin to it, then Klebsiella pneumonia death is sped up several times. After that, we started in vivo trial on mice. This is Mycobacteria smygmatis. And you can see that when we use isoniazid and hexylresorcinol, the number of CFU in mice spleen significantly decreases. These are the data on the sepsis in white mice, polymyxin plus hexylresorcin. So, on the 5th day of observation, actually all of them died, but when polymyxin was used together with hexylresorcin, then on day 13 and on day 12, all the animals were alive. It shows that this area is quite promising. And it actually means that we need to study the genes that mediate adaptive resistance or transitory resistance, because it is also genetically mediated. These genes should be studied. We need to develop test systems. And just like resistance genes, we should determine tolerance genes. And in conclusion, I would like to say the following. Test systems that determine adaptation are important for us to develop, and also we need correction of antimicrobial therapy and prevention, taking into account persistent forms, and we also need to search and try combinations of antibiotics that allow us to overcome the resistance that had already been generated. This is also an important area for research. So there is so-called adjuvant antimicrobial therapy, and actually it's quite similar to adjuvant chemotherapy. And also, we need development of new forms of antimicrobial substances. These are binary drugs that I already described. Thank you. Thank you, Alexey Viktorovich. And in a few words, I would like to emphasize that in this presentation, you introduced the first results of our pilot project conducted by Russian Watchdog for Consumer Protection today, and I think that this is the first attempt to systemically analyze and control healthcare-associated infections and their agents. Thanks a lot, Tatiana. So, the next presentation will be conducted via Skype, as I understand. Professor Elizabeth Taylor will speak. So, can we connect here now? Okay.
Colleagues, and I'm delighted to be here and apologise that my colleague, Dr. Getahan Debresi, who is the head of the Global Secretariat, has been booked an urgent meeting, so I will give the presentation on his behalf. If I could have my first slide. If there is a problem with this, I can present my own slides. Whichever the conference organisers would prefer.
Коллеги, слайды будут у нас?
Colleagues, are we able to show the slides?
Colleagues, could I have an indicator from the conference organisers whether you would like me to present my own slides?
Elizabeth,
yes.
Please run slides on your computer.
You would like me to share my... Okay, that's fine. So, colleagues, as I say, I'm delighted on behalf of WHO and the tripartite to talk about the One Health and global response to antimicrobial prevention. Antimicrobial resistance is a global threat and one of the most pressing threats, not only the developments of 20th century medicine, such as cancer treatments, invasive surgery, and anything that requires immunosuppression or medical care. It is also a major threat in the developing world and emerging nations, which still have a major burden of infection. And it is these countries with the least resilient health systems where the burden will be greatest. We are already seeing the threats and dangers of resistance through tuberculosis, through untreatable neonatal sepsis, but it is very often silenced, a problem that goes undetected because in most of the world, capacity to identify resistant infections is very weak. We talk a lot about the future risks of resistance.
Мы часто говорим о будущих рисках резистентности. Здесь вы видите данные, согласно
but high, and particularly again in low and middle income countries. There may be biases in this data, but it is a very real and current problem across the world. And for this reason, this is something that is being addressed not only through the health system, but has to be seen as a part of the sustainable development agenda. It is a problem that is emerging from the abuse of antimicrobials, not only in the human sector, but in animals, in food production, and through pollution of the environment. And it is by working through these sectors across in partnership sectors that we will make progress. And if we make progress on other elements of the Sustainable Development Goals, on improving water and sanitation supply, on developing sustainable production of food and antimicrobials, that will also make huge progress towards the control of antimicrobial resistance. We are delighted that there is now a specific indicator on AMR within the Sustainable Development Goals, and we are asking all countries to track the proportion of patients with bloodstream infections due to selective microbial contamination. And how have we got into this problem? And it really is that antimicrobials across the world have very often been used as a substitute for good care, good hygiene. These pictures are from where I've been working in Africa, but the problem is the same in the United Kingdom, where I come from, and across the world. That we don't pay enough attention to infection prevention and control. Physicians, particularly when busy, will provide antibiotics, will prescribe antibiotics as a way of satisfying the patient and dealing with them quickly, without perhaps exploring, making a proper diagnosis and a better care pathway. And of course, in many parts of the world, antimicrobials are available over the counter or over the market store with no professional support at all. And this is a problem in the human health sector, but it's also a problem in animal health, where there is a big desire to intensify agriculture. There's a huge demand for cheap meat, and we have found that we can keep animals in overcrowded and insanitary conditions if we use large amounts of prophylactic antibiotics. The problem is also compounded by the fact that small amounts of antibiotics result in growth promotion, and so they are very often routinely used and added to the food of animals to support growth. This is something that many countries are banning now, and we are very keen should be phased out as quickly as possible. Because obviously subtherapeutic doses can create huge problems. But the problems of resistance also occur in the environment. The evidence base of the importance of antimicrobials in the environment is growing, but we know that whether it is from waste from pharmaceutical manufacture or from effluent from either feces of animals or the urine of animals or from hospital waste, a large amount of antimicrobial residue gets into the environment, into soil and wastewater. And there are obviously resistant organisms from feces, from contamination, from everywhere, also there. So the risk of the development and transmission of resistant strains in the environment is also very important. So the need to strengthen our sanitary pollution control is also fundamental. And the need for us to work with colleagues in the environment, in the UN Environment Programme, is also extremely important. Now, the rising tide of resistance would be a problem enough were it not for the fact that the antibiotic pipeline is also almost dry. As has been said, developing antibiotics is difficult. There was a golden age in the 1930s and about 1980, where, as can be seen from the slide, a large number of the major classes of antibiotics were developed, and we felt we had access to cheap, effective drugs, and this was very easy. And that really has stopped since the 1980s. Partly because it's much more difficult. We don't seem to be able to find, the science is harder to find new antimicrobial agents that are effective. And also because of market failure, because pharmaceutical companies can make more profit through drugs for non-communicable diseases that people will take for a lifetime. So we have a major crisis, really, as has been said, with very few new drugs in production, and most of the ones that are being developed are not truly novel. We have a list of priority pathogens that WHO provides to try and shape that research agenda. There is work done to try and stimulate it, but it is nevertheless might face a very dry pipeline of new products. So it is all estimated, and this data comes before COVID, and COVID has very much taught us just how big the impact of untreatable infection can be. But even before then, we were thinking that if we don't address this properly, we could be dealing with economic impact on a similar basis to the 2008 crisis. But this is a dent in the global economy and productivity that will continue. There will be no rapid bounce back. And there's been quite a lot of discussion on what the impact of COVID will be on antimicrobial resistance. And I think at the moment we're still not sure. Certainly, it has helped that the world is now much more aware of the importance of preventing infection and the risks of not doing it. And there has been a lot less burden of infection. We haven't seen a flu season this year. But against this, we know there has been widespread use of antibiotics inappropriately in the treatment of COVID, a massive disruption of programs, and a shift of political focus and thinking. Now, in order to address this, in 2015, a global action plan was developed. All member states of WHO came together and endorsed this plan, which is really a straightforward public health plan, focusing on the importance of developing awareness, strengthening our knowledge and surveillance, optimizing use, reducing infection, and developing new products. And this plan was endorsed by the Food and Agriculture Organization and by the Organization of Animal Health. And countries, all member states of WHO, committed to also develop their national action plans to take this forward. What is encouraging is that by January this year, 143 countries had their plans, and many countries are now developing their second or third plans. What is much more worrying is that many countries lack the capacity and resources to actually implement their plans. So going to scale still remains a major challenge. But just to unpack some of the things of what the importance of infection and what we in WHO and with our colleagues in the Food and Agriculture and Organization of Animal Health are doing, there is a big focus on the prevention of infection. We have Hand Hygiene Week this week. We really encourage just the basics of hand hygiene, which can make such a difference. But immunization is also very important, because if we prevent infections, then people don't need the antibiotics.
Проводим вакцинацию, то антибиотики, их использовали просто вот нападает необходимость.
No, just basic water, sanitation and hygiene provision in communities and health workers, in health facilities, is incredibly important. And 40% of facilities in Africa lack these basic resources. So this is a major feature of the plan in human health. It's also a major feature in animal health. Have strength and wash to prevent the development and transmission of infection. When we, 6 years ago, there was no global surveillance system, and we had very, very little data on what was going on in many countries in terms of the development of resistance. And the data is still patchy, and there are biases, but we now have a global surveillance system. Over 100 countries have joined, but they start to put in their data, and that will start to give a much better picture of what is going on. And we need to have better understanding, not only of where resistance is emerging, the levels of resistance, but also how much antibiotics are consumed, so that we can really manage and understand the global practice. And this data, we've been very data poor. We now to really have that understanding so we can manage the system and take it forward. And this data on resistance and consumption patterns can inform our stewardship decisions. The whole business of using antibiotics much more judiciously is extremely important. It's an important thing to balance access, because we still know that in many countries people are dying because they don't have access to effective antibiotics. So we must sustain access for those who need them, but prevent inappropriate use. As has already been discussed, the AWARE classification is a way of encouraging physicians and those involved in medicines management to use the first-line drugs, which are effective, narrow spectrum, and where the risks of resistance are much lower, so that the more specialized drugs in the reserve capacity can be used for when there is a real crisis in hospital and the last-line treatment drugs are preserved. But it's important that we use antibiotics judiciously, not only in hospitals, but also in the community and in primary care, where there is a huge amount of use and ongoing use. And we need to work with our colleagues in the veterinary sector to ensure that they too use antibiotics appropriately. We have a list of drugs, the critically important drugs, that we discourage use in antibiotics in animals, so that they can be preserved for effective human use. So we work together as a tripartite. We have now established a tripartite joint secretariat that works together to coordinate action, support the development of global governance structures, a multi-partner trust fund established to support work together at country level on these One Health agendas. And we are very delighted that Dr. Anna Popova has joined the Global Leaders Group, which was established in January this year. As you can see, this is a group of leaders, ministers, chaired by 2 prime ministers, with also scientific and private sector leaders from all sectors, from human health, from animal health, from the environment, who are coming together to drive and lead and advocate for the AMR agenda. And we will also be establishing an independent panel rather like the panel on climate change that provides global evidence on the state of the problem, of the issue, and advises on what needs to be done. That panel of experts will be established in the next year, and also a civil society and private sector. So, in summary, thank you very much for inviting us. My key messages are that AMR is a global threat and it's a real and present threat now, but it will get very much worse if we don't prevent and really act now. And this has to be action not only in the human health sector, but in partnership with those working in animal health, in the environment, and the food sector. Thank you very much.
Thank you very much, Dr. Taylor, for your interesting report. Thank you very much. А мы продолжаем.
We move on, and I would like to present the next speaker. It will be carried out by Professor Priputkevich. The floor is yours. Well, good morning, dear colleagues. My message will be on the following topic. We will be sharing with you the information on how we prevent antibiotic resistance in maternity houses, maternity houses, how we keep under control pathogens that are most typical for such hospitals, those who lead to infections of newborns, and so on. Can I have my slides on, please? First of all, I would like to start from the fact that in recent years we see major changes in operations of maternity houses. Here you can see a number of documents adopted in Russia recently that coordinate operations of maternity houses in Russia. And we can see that one of the indicators is as follows: the reduction of newborn deaths in Russia, which is extremely significant. It should have been reduced a few times, but I should say that in 2020, the newborn death was at a very low level. And today, we have more than 1,000 institutions that provide a very high-level service. 124 of them have a status of perinatal centers. Certainly, development of perinatal development dictate command providing high-level services, and that's what we do in our institutions. And we see here what contingent of people we have to work with. We have women with various health issues, natural abortions, and so on, and a number of pathologies. Sometimes it could be even oncology. It's not an exceptional case these days. That leads to the fact that many patients of ours have been taken hormones and antibacterial agents that could lead to the born of infants with some infectious pathologies, and newborns that are born prematurely. And certainly we see here a certain level of risk and proneness to infections, especially while providing medical services. If we look at the incidence and number of deaths among newborns, we see that the share of a high share of deaths are accounted to perinatal centers, as well as distribution of newborns that were dead alive, but that were born alive, but dead shortly afterwards. So this data we got from the statistics of the Ministry of Health. And therefore, today, there has been adopted a program of audits. We do not like this word because it has little to do with the work of our hospitals. But anyways, we are talking about regular checks performed by a number of specialists, including epidemiologists and bacteriologists and other experts. And one of the assessments they have to carry out is evaluation of epidemic safety and prevention of infecting, as well as pharmacovigilance. Well, today we do understand that in Russia there have been carried out two very important programs adopted by the government of the Russian Federation. First is the strategy of preventing antimicrobial resistance in the Russian Federation up to 2030. And today we have been developed a number of reference centers, including the Russian surveillance agency Rospotrebnadzor, and we have been carrying out a project Alexei Viktorovich has been talking about. We certainly see that significant steps are being made in order to improve this situation, and so that antibiotic resistance would be kept under permanent control. And in particular, our work, we perform our work on the weekly basis. You see that our teams of 7 to 6 people visit various Russian regions. On this slide, you see that more than 50 regions have already been visited by the representatives of our national center, perinatal center, and as I said, this program started 2 years ago that allowed us to conduct an analysis in order to find gaps or flaws that could be eliminated in order to improve the overall performance. And certainly we should not just discuss the problems, but we have to find solutions. First of all, we paid attention to the fact that there are differences in structures, organizational structures of various medical institutions. Even if we talk about perinatal institutions, first of all, it's a lack of personnel, lack of high qualified personnel in order to follow sanitation requirements. I'm talking about epidemiologists. Sometimes some perinatal centers do not have them at all. Bacteriologists, clinical pharmacologists that, as you see, account for 0.1% only of overall personnel that work in maternity hospitals. Without those specialists to perform appropriate control in order to reduce infections is next to impossible. Certainly, we talk about big disparities in work of different departments, for example, in surgical department or maternity department. And even in perinatal centers of the Russian Federation, there are a number of differences. I would not stop on details as we are limited on time, but you can find them on that slide. Nevertheless, when we talk about the pilot project, we can say that a number of actions have been made, and the analysis of the work shows that we can overcome the fear of registration infections that were detected while providing medical services, and we see that those medical organizations, hospitals that register infections, they have higher rates of infections, given that they provide objective statistics. We want to encourage all medical centers to not to be afraid, not to be scared, but provide us with objective data in order to take needed actions in future. The same goes for pregnant women. We see that the data differ greatly. If you see 0% of infection, it doesn't mean that there are no infections at all. Our expert is a pilot expert in pilot center in this project, and we do hope that at the end of by the end of the project, we will be able to show very encouraging figures. In the Russian Federation, as some infections are not still registered in medical hospitals, it is very difficult to get the clear picture, but we nevertheless are pretty optimistic. We hope that this practice will be commonplace in a very near future, even if it sounds optimistic. Another issue is that there is no plan regarding etiological structure of the infections. But one of the biggest issue is lack of microbiological laboratories in many medical hospitals, in maternity hospitals, including perinatal centers. So we talk about organizations that have intensive care units, those who take care of quite patients with quite complicated issues. They certainly must establish such labs. And microbiological tests shall be done regularly. On this slide, we see the centers that have their own labs, but there is another problem. Even if medical hospital has a lab, most of them, 80% of them, use manual methodology. Certainly, perinatal medicine today requires high-tech equipment that will make it possible not just detect, not just understand the structure of pathogen, but and perform genetical tests to assess antimicrobial resistance, prevalence of those strains, and provide antimicrobial therapy that is needed. So microbiology today shouldn't be only fast, but it should be of high quality. Our center certainly studies etiological structure of infections that are typical for maternity houses. And certainly we know our main enemies are microbiological agents that lead to those infections. In the recent years, we see the reduction of sensitivity to common microorganisms, or simple, we are talking about E. coli, Staphylococcus, Streptococcus of the big group. And I'm talking about outpatient departments sometimes, not about in the inpatient department where antimicrobial resistance could be much higher. So we see that antimicrobial resistance is getting higher and higher. We see the reduction of sensitivity to Streptococcus agalacti, which is the microorganism number one in leading to in-womb infections. And today we are still the country that does not provide proper control of this infection, and even there have been certain criminal cases initiated against doctors due to the neglect of this infection. It is believed that this agent is sensitive to penicillin agents, the first antibiotics that are given to newborns in terms of infection complications. But in order to prevent those infections, we have to take some measures to eradicate them. And there are a number of countries that successfully control this infection before a newborn is before baby is born. They provide a screening of pregnant women and provide antibiotic prophylactic measures in order to eliminate it during pregnancy. If we talk about prevention, we shouldn't use penicillin agents, as there are a number of contradictions. So sometimes we have to use antibiotics that, as of 27, that show high resilience, that have high resilience with. Next pathogen is Gardnerella vaginalis, one of the more biggest problems for us that lead to vaginosis and so on. We would say there is metronidazole that helps to treat this pathogen, but having conducted a number of trials, not with a large number of patients, but nevertheless, we see that metronidazole shows 100% resistance, and that has been described in our practice. So when we prescribe to pregnant women metronidazole, we probably should ask ourselves, why do we do it? Next infections are Staphylococcus infections. This is a very old problem, and starting from perinatal centers and other departments, hospital departments, we know that they could lead to outbreaks in departments where which face this problem on a common basis. For neonatology, there is one more problem. Apart from golden staphylococcus, in the group of prematurely born children, the number one pathogen is CONC. So, in other words, we fight with two pathogens that have to be monitored. If we talk today about operations of maternity houses, we should understand that CONC and golden staphylococcus lead to a number of serious problems, and they show a very high resistance to beta-lactam agents and even medicines that have been used as a reserved agents. So, in other words, we see a very high resistance. And this height and such prevalence is seen in a number of number of medicines. So for a number of years, together with Vladimir Sotorenko and his lab, we have been conducting a monitoring when we track the resistance of CONC, and we detected that today we have two clones of Staphylococcus Comimus, and Sergei Vladimirovich here performed an investigation. We have an idea exactly how they were brought to our hospital. Our children, after all, they get a very intensive treatment after cardio surgeries, and certainly we should do our best in order to eradicate those pathogens indoors in the hospital. And to conclude my presentation, I would like to say the following. We know the main mechanism of resistance of microorganisms, and we know that there are a number of testing kits that allow to detect genes of resistance, but why shall we do regular continuous monitoring? Monitoring, the word itself says it shall be continuous. Why shall we introduce new methodologies to detect resistance? So that we have adequate testing kits and that could be used in the clinical practice. And today we have a question. Shall we include Gencifir into such panels? So, dear colleagues, we do understand that this work is extremely important. I hope it will be carried out in future. As I said, we are a reference center in neonatology. We hope we are going to cooperate in future with Rоспотребнадзор, and we will get success in future. Thank you very much, Tatiana Valerievna. Thank you for your report. Thanks for your fantastic report. Unfortunately, we are very limited in time, so now I would like to give a floor to a group of authors from Pirogov Medical Center, and I would like to pass the floor to Daria Kamyshova. Good afternoon, dear colleagues. Today I introduced the Pirogov Medical Center and our vision of monitoring antibiotic resistance. So it's a natural feature of microorganisms that is given to them by nature, but as we know, antibiotics have been part of our everyday life. They have been used in medicine, in agriculture, and so on. And we know that resistance is a very big problem, and negligence of this problem by medical directors and lack of adequate measures in order to prevent antibiotic resistance lead to the fact that the problem and infections that get out of control. And we do understand that antibiotic resistance leads to lots of labor costs and this threat the lives of our patients. Besides, it's a very expensive problem. In order to evaluate the burden of antibiotic resistance, we performed a trial in our medical center that specializes on treatment of patients with antibiotic resistance. So we had two groups of patients. One had genes of resistance to antibiotics, and the second group didn't have it. And as it turned out, the presence of antibiotic resistance really influences the two clinical outcomes. We see that median of hospital admissions among patients with antibiotic resistance is 7 days compared to 2 days in the second group. And as for mortality rate, it's twice as high as in patients that do not have resistance. Certainly, it affects badly the economic costs of treatment. An average cost of one treatment is 4 times as high compared with no antibiotic resistance. If we talk about why did we pay attention to this problem in 2011, look at the level of antibiotic resistance. We see that level of ESBL 80-90 carbonema 26%, and that was 10 years ago. If we talk about non-enzyme bacteria, so to the nature of antibiotics, it was 60 to 100%. And as for prevalence of SK bacteremia, it was 101 cases. So certainly we took measures in order to establish a control strategy. We developed, we established a team and started to introduce additional measures on the annual basis in order to provide successful antimicrobial therapy. Recently, we have been dealing with the detection of antibiotic resistance. Every year, we try to adjust protocol of antimicrobial protocol. It's one-time monitoring. We analyze data, compare them with the last year data, and into 2020, we got a decree on antibiotic resistance. According to this decree, we have to conduct a regular monitoring For departments where we have
членов команды SCAT, and the roles were allocated according to the reaction to this situation. So it gives us an understanding and an opportunity to respond as fast as possible to these problems. Antimicrobial stewardship team in our inpatient facility. This is the scheme that includes protocols, educational events, the system of control and safety, as well as internal audit. All of that allows us to prevent the abuse of antibiotics and increase the level of infection safety in the inpatient facility. And, for example, speaking about the dynamics of consumption in the inpatient facility, we can see that since 2013, the consumption of antibiotics per 100 bed days in the inpatient facility has decreased twice, and the annual growth in the number of patients since 2013 has more than doubled. And given that in the inpatient facility, we understand that zero level of safety cannot be achieved. So it's important to understand what agent is the basis of infection. That's why the decrease of escape group in our facility allows us to select the best empirical antimicrobial therapy. And the structure of escape agents in the total structure of our agents actually has decreased 2 times since 2013. The protocol of empirical antimicrobial therapy is a key instrument to control antimicrobial resistance in the inpatient facility, but it requires a lot of work. This work is very subtle, so the version of protocol that appeared earlier, actually the basis of risk stratification, was based on a situation when a patient stayed in ICU for more than 3 days, and we had type 3B. But thanks to monitoring of antimicrobial resistance, we saw the excessive use of carbapenem that are frequently used as empirical therapy. We have amended our risk stratification because the level of infection control in our inpatient facility allows us to shift these terms. So our patients can be colonized by polyresistant agents after a later time. So we have analyzed whether it was actually logical to do so. And you can see that in the group of carbapenem-resistant Klebsiella and Pseudomonas aeruginosa, all of them are related to group 3B in 100% of cases, and as a result, we saw the decrease of consumption of carbapenem of group 2 by the factor of 2. We think that the most important indicator of resistance decrease, as I said, in 2011, non-fermenting agents had the level of resistance of 60 to 100%, and in 2019, the level of non-resistance of Pseudomonas aeruginosa was 45%. And we understand that this is a high level of lack of resistance. But speaking about non-fermenting microorganisms, of course, the system of infection safety and control is very important. That's why in Pirogov Center we pay a lot of attention to screening of polyresistant agents and fast response of infection control, effective disinfection of surfaces, hand hygiene to prevent further dissemination. And you can see that the share of non-fermenting microorganisms trained in the general structure is not a problem for us. So the share of Acinetobacter has decreased. It is 0.7%, and Pseudomonas aeruginosa is 4.2%. An important component of every control strategy of all complex measures is educating personnel. So we think that a lot of attention should be paid to it. It's important. So it's important not only to train doctors, but also to train the team of antimicrobial stewardship because we need continuous increase of knowledge. These are the results of our training programs. We have analyzed the terms of de-escalation. You know that in ICU, de-escalation is quite complicated because the patients are in severe conditions and it's not always possible. In 2017, the timeframes of de-escalation were 3.75 days, and in January 2020 it was 1.88 days. And of course, a major role here was played by the development of bacteriological lab that can give us data on microbiological structure in a faster manner, and we can respond faster in terms of de-escalation. So actually I asked to shrink my presentation, but okay, I can speak about it as well. This is an anti-example, COVID-19. So Pirogov Center in 2020 had a hospital and it actually worked. So I can actually skip the slides probably. Here the main goal was to show that when we face a problem that we cannot really control, that we're not aware of, then still it happens that, well, we cannot respond as fast as we can do regarding our current problems. So in COVID-19, we had such a trend as resistance, especially non-fermenting microorganisms, because COVID-19 actually made us face a lot of problems. We lacked staff, for example, and some other issues. And this is my last slide. I wanted to thank you for your attention, and I wanted to thank the team of Pirogov Center for their everyday work, thanks to which we can show these brilliant results. Thanks a lot, Daria Andreevna, for your interesting presentation. So we've had some round of applause here, although we're not numerous in this room. And now we'd like to give the floor to Professor Sergei Vladimirovich Sidorenko. You can see him right now. We're very glad to see you, Sergei Vladimirovich. For a long time, we have discussed the issue of virulence and resistance. There are some hypotheses that resistance is accompanied by increased virulence, and there is an opposite standpoint that states that resistance is always about adding some additional genetic information, and it results in decreased adaptivity of microbe and decrease of virulence. But actually, there is no silver bullet here, no universal solution, and today I would like to speak about one microbe and the way of virulence and resistance, whether they go together or not. I will speak about Klebsiella pneumoniae. Well, actually, this book was developed quite a long time ago. It was described in 19th century, and lethality was high, up to 70%. First of all, this was pneumonia. So sometimes they felt that it was pneumococcus, and actually localizations were different. Abscess of soft tissues, liver, kidneys, and others. And during that time, people frequently noticed that colonies of Klebsiella, some of them have hypermucoid phenotype, and I will actually show you the way it looks like. Actually, today, Klebsiella, well, after molecular methods appeared, actually now we know a complex of Klebsiella pneumonia that includes various species, Polycora, Africana, Quasivicona, and it's actually impossible to differentiate them with classical methods. We need to use molecular methods for it. And they have never said that all Klebsiellas for some time were not reviewed. And over the last 10 years, we have had classical Klebsiellas that actually resulted in healthcare-associated infections. They could be localized in various places. And actually their virulence was quite low. We cannot say that they were completely not virulent, but still. So previous speaker mentioned that as well. The most unpleasant thing regarding Klebsiellas is that they generated multiple resistance very fast. And today there are about 5 to 7 plasmids, and frequently they develop pan resistance and hypervirulent lines. Well, about in the 80s, in southeastern Egypt, they started registering diseases in healthy people without comorbidities. However, they had quite typical localizations, such as endophthalitis, meningitis, brain abscess, and liver abscess. And what is important here? Actually, it was sensitive to antibiotics, and if the diagnostics and treatment were timely, it was possible to stop it. When they checked this Klebsiella in mice, they showed quite high virulence, less than 10 to the point of -3 COE. That is very low. They can be localized on chromosomes and plasmids, and plasmids are huge, 200,000 pairs of bases, and today we do not have a consensus. We cannot clearly state what signs, what genes are 100% necessary for virulence appearance. Sergey Vladimirovich, actually, you are not changing your slides. You know it? Could you please switch on the slides, because now we can see only one slide, I guess the first one. Can you see my slides now? Not yet. We do not see it. We do not see you. What about now? Can you see it now? No. I request organizers to help us. Yes, now I can see it. Okay, thank you. So, I mentioned that there are two lines here, hypervirulent and sensitive to antibiotics, low virulent but resistant to antibiotics. So what happened recently? Well, actually this information will be described a bit later. What is the difference between hypervirulent and classical type? In hypervirulent type, the capsule is much thicker. And another important point is that apart from siderophores that are typical for normal Klebsiella, there are two more siderophores, pseudophilin ivermectin. Normally, this is a capsule type K1, K2. But what is important for practice? In 2018, the first publication appeared in China stating that there are strains of Klebsiella that showed hypervirulence and multiple resistance. This is the first work from China that describes this hypervirulent Klebsiella. This is the way it looks like in a plate. So you can see that it's quite long. This is a positive strain test. And this Klebsiella had KDP. They showed virulence on positive neutrophil test. They gave 100% lethality on bee moth larvae. This is a surrogate test, not to kill the mice. We decided to use the larvae. And they had virulent plasmid. So this is the first publication of 2018, and since that time, this has been a very relevant problem globally. And what's going on now? These are the first works. Here there are two genetic lines of Klebsiella, 395 and 147 types. And this is the top line. It's actually marked gray. They showed lethality of mice, 10 to the point of 2. They had maximum possible set of virulence determinants, and they had beta-lactamase, DN1 type. And at that time, we were not able to identify plasmids. I mean the genetic determinants where they were localized, and what are the possible ways of resistance formation when hypervirulent isolates of plasmids receive genes of resistance, and also when multiple resistance isolates of plasmids get virulence genes, and the worst case is when hybrid plasmids are formed, when virulent plasmids have resistance genes, or when resistance plasmids have virulence genes. And what happens most frequently, according to the global experience, we can see this process when virulent plasmids get resistance genes. And this is continuation of our work. Recently, we have found a number of isolates. So at first, we had only 390 and 147. Now we have 390, 874, and others. These are various capsule serotypes. Serotype 2, and serotype 2 is most typical. And most of them have genes, BLA genes, and in one isolate we found a new carbapenemase that has not been described before. This is NDM29. They showed high index of virulence and resistance. What did we do next? At the early stage, we could conduct full genome sequencing on Illumina platform. It is characterized by high accuracy and short reads, but after this full genome sequencing, we cannot divide plasmid from chromosome, so we added full genome sequencing on Oxford Nanopore platform. This is one sequencer, and Oxford Nanopore, this is another device that is just a bit larger than a computer stick. And here we were able to get very long reads, but quite a high error rate. And combining these two approaches, we were able to get long reads and high frequency. This is hybrid assembly that allows us to get annular plasmids with chromosomes. And today we understand that Russian plasmids, you can see it here actually, well, they originate from Europe and Great Britain. This is British virulent plasmid, and this is its relative in Russia. And what does it have? It has this small piece. And here, beta-lactamase NDM type gene is. These are two variants of plasmids. So it means that on some stage, we're not sure whether it was in Russia, in Great Britain, or in a different country. Actually, this gene was acquired by hypervirulent plasmid. And let's look at the plasmids that circulate in Russia and globally. And the closest relative of our plasmid, you can see it here. So the gray color between two lines means that they are identical. So actually, we cannot see two identical plasmids. So somewhere we see very intensive genetic processes, and our plasmids are very similar to the plasmids from Great Britain and Czech Republic. So today we see a very unpleasant picture, new phenotype appearance. It will be difficult to treat it because of resistance, and it will cause high lethality due to hypervirulence. And of course, this is one of the most serious threats to the healthcare system. The first stage to prevent dissemination of such virulent and multiple resistant Klebsiella is convergence of hypervirulence. Actually, the first stage is to find VIR and MDR Klebsiella. So if we have this effect, we should suppose that hypervirulence is there, and clinicians should pay special attention to abscess, meningitis, and endophthalmitis. So if on early stage we are not able to detect and monitor and somehow prevent further dissemination of such hypervirulent Klebsiellas, then potentially we can experience not only post-genome era, but also hypervirulent era. So I call on cooperation. Microbiologists should detect these isolates at an early stage. And of course, we have antimicrobial stewardship program, and this is one of the goals of such program because this antimicrobial stewardship program allows us to build a constructive dialogue between the clinic and the laboratory. And the sooner we start detecting these isolates in our inpatient facilities, the more chances we have to avoid that. Thank you, Sergey Vladimirovich, for your interesting presentation. And our final presentation, Ildar Renatovich, who represents Gabrichevsky Institute, will be presenting. The floor is yours.
Да? По 30, не важно. Мне кажется, все уже.
Еще 10 минут.
Да? Ну ладно. So, dear colleagues, I would like to introduce you the report of strategy of FAGA-mediated control as a guarantee of safety of food products. Innovation use of bacteriophage included two main components: bacteriophage-mediated control and measures to prevent bacterial contaminations of animals and processing food and phage-mediated processing in order to prolong shelf life of meat and other food products before they are packaged in semi-product foods. As for microbiological safety in 21st century, it's still a very relevant problem. New ways to store products in vacuum packaging, minimum processing, longer transportation, and lack to follow hygiene requirements by the personnel lead to a higher risk of contaminating products with salmonella, Cultibacter, Listeria, and other pathogens. Application of antibiotics in food industry does not help to eradicate the problem and lead to the emergence of new pathogens, new strains of pathogen agents that are resistant to antibiotics. In America, Canada, and the UAE countries, the increase of cases of outbreaks that are transferred with food led to the development of new segments of products based on bacteriophages. Agency of Environment Safety, starting from 2005, started to register such products as pesticides. FDA in the US, starting from 2006, registers phage-containing products as supplements. And as a case for phage-mediated control, I would like to introduce the biopesticide, including bacteriophage agrophage that has a cocktail of virulent phages that is active against bacteria that affect tomatoes, pepper, and soil. Efficacy of using bacteriophages on pepper compared to chemical pesticides is shown on slides. In 2007, Amniolytics and Delanka got approval of FDA and Ministry of Agriculture based on bacteriophage against a number of bacteria for treating animals before going to slaughter. To illustrate the efficacy of phage-mediated products, we can have a look at FDA technological supplement that uses a cocktail list shield. It includes 6 various bacteriophages that more than 170 strains are sensitive to, and it allows to produce ready-to-use meat and poultry. This supplement is used before packaging meat at processing plants and poultry factories, as well as doing semi-ready products by using spray treatment. FDA recognized Listix supplement as a part of the GRAS list, which means that they are safe and can be used in the food industry. In the food industry, it can be also used in cheese production, and later on in 2007, it was recognized and approved to be used for other food products. In 2011, Intralytics introduced a cocktail containing 3 virulent bacteriophage that are part of mere viruses. They were divided from seawater, and they're active to 111 strains of E. coli, 76 strains of a number of E. coli bacteria, and could be used during processing of raw meat. Also showed a very high efficacy during 96 hours for 95%, which was equal to 95%. In the same year, Holland Medical Expert Advice Agency approved to use bacteriophage in order to eradicate salmonella on the site of the one largest poultry production sites. And later on, it was introduced in order to approved by FDA, a SalmonFresh cocktail that's specifically active against high pathogen salmonella strains. Within the research program approved by the Russian surveillance agency Rospotrebnadzor, we have developed a number of products in order to prolong life shelf of a number of food products, such as ground meat, dairy products, and so on. Here you can see stages of development of phage containing products, starting from dilution of those products and registration with the surveillance agency. Here you can see the first technological supplement with ACD7. It is sensitive to it is sensitive to E. coli and other cell groups. As for phage-mediated products, it made it possible to irradiate E. coli in ground meat within 24 hours. One of the strongest features is ability to lysize a number of a wide group of pathogens. Together with a reference lab of the European Union, we have divided colifax in order to lysize the toxin strains E. coli. 44 out of 51 strains have been lysed in Moscow, in the Moscow region. Therefore, it was proved that our phage are effective against Escherichia coli that have been circulated in the European Union. To use them in dairy industry, we have developed a supplement with the use of bacteriophage ESD together with bacteriophage stack against Staphylococcus. The processing together with said bacteriophages make it possible to reduce the amount of pathogens by 99% within a few hours. The third product of decontamination is technical supplement based on 3 bacteriophages that are active against Salmonella enteriditis. On this table, you can see the design of the trial to eliminate Salmonella from poultry semi-ready products. Previously checked parts of poultry have been contaminated with E. coli in the amount shown on the slide. The pieces were treated with bacteriophage with a different type, and 48 hours later, we saw the full elimination of salmonella in both series of the trial, while the level of salmonella in control samples was very high. In order to disseminate the bacteria in swine, in beef and swine meat, we used bacteriophages against which that are active against a number of salmonella strains. It was treated. We treated the meat with bacteriophages, and it showed a very high efficacy. Microbiological monitoring was performed during the whole shelf life of the product. Samples from control and trial groups were kept at the temperature of 2 to 4 degrees. According to the technical protocol of the customs control, E. coli was identified in the samples that were not treated with bacteriophages. On the second days in this sample treated with bacteriophages, there was no E. coli, while the control samples contained an increased amount of E. coli. Developing decontamination agents for chilled fish, we found out that a number of bacteria that are present on the surface of the skin can lead to infections in fish, but and also lead to a shorter shelf life, and with improper processing, they could lead to toxic infection among humans. The additional factor to detect microbials on the surface is disinfection of the production sites and the equipment that could lead to a higher risk of microbial biofilms on the surfaces that are concocted with the product. Physical methods of equipment leading in the fish industry, they lead to a worse nutritious value of the products and lead to the production of new strains of pathogens that are resistant to antibiotics. Due to the said information, we wanted to create a decontamination agent that used polyvalent cocktail of bacteriophages that would be active to strains that lead to the waste of fish products and human infections. We divided and selected prospective strains of bacteriophages, and together with one fish farm, during the processing of fish, of trout, we treated the fish with the bacteriophages. So it was processed by putting into the water that contained bacteriophages. Control of bacterial criteria of the samples showed it's possible to prolong the shelf life by 4 days with preserving ecological safety and nutritious value of the product. Despite the progress in food safety, infectious are still high risk, especially to people with low immune system. Phage-mediated control could be an additional effective tool to prevent pathogens into the food products. This method is especially has a very high potential especially for producers of food industry. Thank you very much for your attention. Well, thank you very much, Eldar Renatovich. Well, we have run out of time. We have no time for any discussion or questions. I would like to Thank you all for your very informative and fantastic reports. Thank you very much for your attention, dear audience, and hope to see you soon.
Коллеги, всем добрый день.
Hello, colleagues. Vyacheslav Yurjevich will come to us a bit later. He's presenting now, so I request our speakers to take their seats, and we're going to begin. А сколько мы будем сейчас? Как ты хочешь? Colleagues, hello once again. I'm very glad to welcome you in our session that is devoted to the Russian program of technical assistance to countries of Eastern Europe and Central Asia on HIV, AIDS, and other infectious diseases. Today, we're having an offline event, and although the pandemic is still on, we actually observe all the measures. And most of us are responsible people, so we have been vaccinated. That's why we can feel safe. In spite of the pandemic of COVID-19, all the infectious disorders and other problems that are faced by the global community are still present. That's why it's so important for us to see that these problems are taken into account by the government, by the civil community. It's important for us to see that these problems are being solved and specific instruments are used for that. So now, I would like to invite here for the first presentation Zoya Konstantinovna Suvorova. She represents Epidemiological Center of the Russian Watchdog for Consumer Protection, and she will speak about the results of Russian programs of technical assistance to Eastern European and Central Asia countries. Actually, this presentation was to be given by the director of our institute, Vasily Akinkin, but unfortunately he is sick. So I will present this presentation instead of him. Distinguished colleagues, it's my pleasure to represent this work on the results of research conducted by the Epidemiological Institute with 6 EECA countries. Participants of this project include Azerbaijan, Armenia, Belarus, Kyrgyzstan, Tajikistan, Uzbekistan, and several Russian regions. The research is conducted in 4 main areas. The common goal uniting these areas is a complex assessment of the impact of mass use of antiretroviral therapy on molecular genetic features of HIV, the characteristics of vulnerable population groups for HIV and TB, and epidemiological process of HIV infection in EECA countries. The research novelty of this project that we expect. For the first time, we will receive data on genetic characteristics of HIV strains that are disseminated in EECA countries. Due to the potential of developing resistance to antiretrovirus drugs, the characteristics of compliance, and susceptibility of population to the treatment of HIV and TB, for the first time, we will receive the complete characteristics of the spectrum of HIV strains with the analysis of their geographical origin and connection with factors of economic integration. So, I offer to consider the results separately in each area. The goal of the study is to prevent dissemination of HIV strains resistant to antiretrovirus therapy. So we need to study the dissemination of HIV strains that are resistant
to antiretroviral therapy. Among such patients, according to the results, we have the level of resistance of HIV in patients before this therapy was from 2.8% in Uzbekistan to 16.7% in Tajikistan. The level of resistance to nucleoside inhibitor of reverse transcriptase was quite low. It was from 0.4% in Uzbekistan to 5.6% in Tajikistan. The level of resistance of HIV to non-nucleoside inhibitor of reverse transcriptase was from 2.8% in Uzbekistan to 11.4% in Tajikistan and Belarus. The cases of HIV resistance to protease inhibitors were not established. The most spread mutation of HIV resistance to NIOT was A62V, that was polymorph for the prevalent variant of HIV of subtype A6, and M41L was found in Belarus, T69D and L210W were found in Armenia. Mutation of drug resistance of HIV to non-nucleoside inhibitors of reverse transcriptase are visible on the slide. The most spread variants of HIV in these countries was subtype A6 that was encountered quite frequently in the republics of Armenia, Azerbaijan, Belarus, and circulating recombinant form O2AG that is most spread in the Republic of Uzbekistan and Republic of Tajikistan. So let's move on to the next trial. Within this trial, a complex analysis of medical, biological, and social demographic factors of the risk of developing TB in patients with HIV. Within this trial, we analyzed epidemiological data gathered in 2019. It was shown that in all countries, we saw a decrease of morbidity and mortality due to TB. Among the patients with HIV, TB was significantly higher compared with the general population. And in this slide, you can see the data on mortality due to tuberculosis over 5 years in all the republics. In this slide, you can see data on the number of patients with HIV and TB broken down by years in all republics. It is shown that among HIV patients who died due to secondary disorders, the share of people who died due to TB was minimum. In Belarus, it was 16.3%, and Vladimir region, it was 21.4%. In other countries, TB was the reason of death of almost half of HIV patients. Over the last 5 years, in most countries, we've seen an increase of drug resistance tests coverage. The least share of tested patients was in Kyrgyzstan, and in Belarus, all patients were tested on drug sensitivity. In all republics, we saw significant differences in the efficiency of anti-TB therapy combined with when tuberculosis was combined with HIV, depending on the presence or absence of multiple drug resistance. The second part of this trial is devoted to genetic polymorphism study. To study them, patients with HIV co-infected with TB, actually most informative genetic markers were taken from them. And as a method to define genetic polymorphism, PCR in real-time mode and PR sequencing were selected. And we consider an opportunity to include special methods for determining all the genetic polymorphisms. We have considered genetic aspects of the risk of syndrome of immune system restoration in patients with TB when antiretrovirus drugs were prescribed. Unfortunately, having studied genetic polymorphisms, we actually had not started studying biological samples. Due to coronavirus, we didn't manage to take them out of the republics that participate in the trial. Following the results of this trial, one article was prepared and one thesis was prepared. We already have the information base of the risk factors of TB development in patients with HIV in the participating countries. The next study is the study of compliance of patients to observation and treatment as a method for preventing HIV. Within this study, a preliminary analysis was conducted. We analyzed the strategy deficiencies and an opportunity to develop compliance in HIV patients. These were patients from 6 countries of EECA, Republic of Tatarstan, and St. Petersburg region. And the results showed a trend to low assessment of opportunity to take care of their health. The risks of compliancy were found in 30% of participants. The most relevant needs of experts in CIS were related to organizational issues of helping patients and receiving additional knowledge. The need to improve psychological competences among the experts was 76.9%. The results we received were provided in the article that was published, and during this trial, an indicator of forecasting compliance was developed. This is compliance to observation and treatment of HIV. We've seen correlation between the indicators of self-assessment of health and readiness to visit doctor and administer therapy due to HIV. I will not dwell upon this study because later it will be represented by Valentina Bidaeva, who is responsible officer on this trial, the next trial. This is the assessment of the development of HIV epidemics by analyzing nucleotide sequences of HIV-1 and related epidemiological data on patients using phylogenetic and Bayes method of trial. This study was conducted in Armenia Republic only. It was shown during this trial that 5.5% of patients who had not taken ERT drugs had drug resistance. And I'd like to point out that resistance in naive patients grew significantly compared with 2009-2010 when it was 1.5%. And in spite of the increase of drug resistance level, the profile of established resistance mutations in most cases does not decrease the efficiency of antiretroviral drugs of the first line. The analysis of transmission clusters in Armenia, just like in the Russian Federation, has shown that there is significant underreporting of cases of infection transmission due to homosexual contacts. In the vulnerable group of men, more frequently, epidemiological connection was found between the samples from Armenia Republic and samples from the Russian Federation. And at the same time, we found low number of transmission clusters with the samples of patients from both the countries. So we can suppose that this epidemic is a bit isolated in Armenia. So we analyzed the results of 4 trials that are still being conducted in all the regions. So these trials have lasted for 2 years and we will have 1 more year. And we hope that in spite of coronavirus, we will manage to take biological samples from all republics and conduct additional trials that had been planned, and during the next conference we will be able to provide complete information on all the trials. Thank you. Thanks a lot. Indeed, an important work was conducted, and I hope that the results will be used to improve the parameters of rendering this kind of assistance. Now I would like to invite here Azamal Buzurukov, who is program coordinator of UNAIDS and who has very vast experience of clinical work in international organizations. So he used to work for WHO, UNICEF, and actually I can enumerate it for a long time. I think that the work of Azam is very indicative, just like the results he achieves and his activity itself. And he will speak about the results of regional cooperation program in EECA countries. Thanks a lot for introducing me. Distinguished colleagues, this presentation was already shown to the members of the coordination committee of the program yesterday, so I will try to develop on some slides in more details. As Victoria Vladimirovna said, this program has been implemented since 2013, and this is the third year of the third phase that was launched in 2019. And the areas implemented within this third phase can be subdivided into several components. The first one is the receipt of important strategic information for preparing and implementing efficient anti-epidemiological measures. Since 2017, we've had a study devoted to recent infection cases. It was quite difficult because we started this trial in 5 countries and every country had its own particular aspects. But we prepared an overall database, and since 2019 we've seen stepwise accumulation of the necessary data. The next component is aimed at preventing HIV among key groups, and a special attention is made to migrating population. Russia is a country that accepts migrants from all the countries: Armenia, Belarus, Kyrgyzstan, Tajikistan, and since 2019 we have had our office in Uzbekistan. The flow of migrants is big, and they represent the group of population that is especially vulnerable to various diseases, including HIV and hepatitis. And we've seen a lot of events aimed at eliminating direct way of transmitting HIV in Central Asia, in particular in Kyrgyzstan and Tajikistan. And the multidisciplinary approach has proven its efficiency. This initiative started in the second phase of the program, and it has developed during the third phase. Of course, this year of pandemic has influenced the recruiting new people in these teams, but they have shown really good results. Information campaigns are also included into this component. This is one of successful measures conducted in all 5 countries of the region at the same time. Of course, each country has its specificity. Social networks are used as well as TV channels. And we can see significant work with young people everywhere. Of course, it's quite costly in terms of energy and finance, but it is quite efficient, speaking about prevention. Infection control. This is a very sensitive issue related to HIV infection in hospitals and medical facilities. Such cases exist. The information about them has been published, and they're being investigated. Because indeed, these cases represent a major problem. They show low level of infectious control in the medical institutions where such cases take place. And we can see them in Middle Asia. So this problem is recognized, and within phase 2 and 3, active work has started to eliminate this problem. And we can already see a serious progress in this area and the decrease of hospital infection. This is an important indicator. So I'd like to say a few words of the results of 2019. This is a year before the pandemic. And we could see very vast extension of the events of such program. In 100 towns in Armenia, mobile services were provided to people on HIV consultation. In Belarus, the coverage of information campaign was more than 2 million people, and in Kyrgyzstan, work was started to prevent hem contact infection, and injection equipment was provided. In Tajikistan, more than 500,000 migrants and members of their families were tested on HIV. The number of clients of multidisciplinary teams in Kyrgyzstan has grown. And in November, UNAIDS office was opened once again in Uzbekistan. So the COVID year started, and it was followed by many unpleasant ramifications, because many events were stopped, many events were transferred to online mode, but in accordance with the analysis done by our experts, this kind of format did not always allow us to train experts in a qualitative manner. It was very difficult to organize everything, to get their feedback, because some things are difficult to be done online, especially speaking about training epidemiologists. So it was decided to support the services aimed at maintaining HIV prevention, especially for people with HIV, for migrants, their family members, and their birth services rendered on maintaining psychological health, especially in the beginning when it was very difficult. There were a lot of apprehensions and quite difficult. A lot of false information was given. That's why the experts that were providing the important information for COVID prevention were in high demand. As I said, this program integrated virtual consultations, and various instruments were developed to collect data. So feedback was developed. For example, the Speed and Connection Fund organized virtual platforms for data collection from all the people involved in the program. In 2020, two very important international events were conducted. Russian organizations such as Russian Watchdog for Consumer Protection participated, as well as international organizations, for example, WHO, UNAIDS, UN Children Foundation, and all the representatives of ministries of all the involved countries. These symposiums, such as the impact of COVID-19 and HIV on achieving development goals and COVID-19 pandemic, that is a challenge to contemporary science. For example, speaking about the last symposium, award was given to the developers of the vaccine, and they had an opportunity to talk to the general public, and that was about 100,000 people that conducted this symposium that were able to get the data. And it is a very significant event, a very relevant event. We estimate it in a very high manner. We received a lot of good feedback from all the participants. Armenia Republic. This is a brief review. It was done yesterday, and I would like to emphasize once again that this pandemic year was very difficult, and Armenia had a war conflict during that year. and our national colleagues were rendering medical assistance. They were invited there, they were helping people there, and still very important events were being conducted. In terms of this program, for example, they conducted trainings for infectionists because there was a dramatic increase of the need in such experts. Mobile clinics were used for testing points. Sport Info Connection Foundation managed to deliver 100,000 test system and COVID-19 tests in this difficult time, and only then these tests were produced by Russian laboratories, and by demand of the Minister of Healthcare they were delivered to Armenia, Belarus Republic. 30,000 PCR tests on COVID-19 were bought there, and they managed to redistribute this means and provide for continuous treatment for 13,000 of patients. 2,000 people with HIV received services of multidisciplinary teams, and today, within this program, a national plan on COVID-19 vaccination is being developed. Kyrgyzstan Republic. Here we have the largest number of mobile clinics. We work actively and they provided services to more than 25,000 people. More than 200 units of sterilization equipment and accessories were bought to implement the program for decreasing hospital infection. Multidisciplinary teams have adapted their work and they provided food and all the necessary things, including personal protection equipment, for families. Tajikistan has its own specificity. There was no overall quarantine, and mobile clinics continued their work on HIV prevention, and they also distributed necessary PPE from coronavirus. They provided about 65,000 people. Active information campaign was conducted in social media, and mobile clinics also conducted this work. And the coverage was more than 100,000 people. The net of these offices was able to render assistance to HIV-infected people and to conduct work on coronavirus prevention. In Uzbekistan, in January 2020, the program was started, but due to COVID, everything was changed. So actually, Uzbekistan was returning towards this program. Uzbekistan was present in the first phase. It was absent in phase 2, and we decided to reconnect it in phase 3. Some things were easier to restore, but we've also seen refocus on prevention and supporting people with HIV. In Samarkand, food was given for families with HIV patients. So they had to adapt in this difficult year, but in November, the first mobile clinic was delivered, and a ceremony for transferring this clinic was conducted. It was a very positive scenario. In 2021, the program implementation was started. So I actually described this program during my first slides. We continue our program on gathering epidemiological data, and we've seen active support of national program in Tajikistan that had been approved before. And we see continuation of professional relationship between Russian, Central Asian, and East European institutions. And we will continue supporting interdisciplinary teams, and we will continue strengthening infectious control in medical facilities. Now I'd like to thank all the participants of the program, all the organizations that were engaged in this program. Indeed, this year was difficult. Many people were affected by this infection. However, Actually, our ancestors managed to win over it, and we will do so. We have a lot of instruments, a lot of potential, a lot of work experience, a lot of capacities, and we really hope that this program will continue, because indeed this program has becomes well structured. It provides for a lot of people, and we hope to receive your support as well as professional support. Thank you.
Well, thank you very much for your fantastic report. It was indeed very interesting to see that the practical activity is continuous. I remember when we were doing the project to evaluate this initiative, we were impressed by the efficacy of those mobile clinics that make it possible to cover large areas with medical services and provide needed help to those who live in remote areas. Therefore, we can't possibly exaggerate the importance of your work. The second thing that I wanted to point out is the importance of awareness, raising awareness and education of the population. It is very important that people understand how to fight those infections, diseases, and as representatives of educational institutions, we shall be in line with the requirements and the current situation. So we are in demand with today's situation. As you remember, last year Russia was the head of the BRICS, and I was an expert, a leading expert there, and we came up with an initiative that together with profile institutions we could organize and promote education and training of volunteers in epidemiological field, because as we have all seen, the pandemic has shown that many health systems could not keep it under control, and certainly additional help was of great importance, and that's information we included in our final conclusion. So we shall apply it not only within BRICS, but at a wider scale. I am pretty sure that UNAIDS and other profile institutions would be very interested in it. And thank you very much again. I would like to pass floor to Valentina Belaeva, who represents the Central Research Institute of Rospodrebnadzor, the Russian surveillance agency, and she has extensive experience in this field. She is an author of many scientific articles, and so she is a very prominent researcher. She will be talking about risks and resources of medical adherence of treatment of which infection. Valentina, the floor is yours. Thank you very much. Colleagues, may I have my slides on screen, please? So, dear colleagues, we all understand that the main player and executor of all our recommendations, our programs, is a human being. People, in other words. People want to protect their health. We want to eliminate risks of HIV and other infections. But if it happens, we expect patients to follow our recommendations and take antiretroviral therapy agents. So that means that he is dedicated. So compliance is extremely important to us in order to protect patients' health. And antiretroviral therapy is essential in this regard. The patient to see how compliant he is, and what are the reasons to stop the treatment. As I said, the compliance is our key word, and this term we are going to use later on. You see that we have two regions of the Russian Federation, the Leningrad region and the Republic of Tatarstan. They took part in our trial. What did we do in 2019 and 2020? We we made a questionnaire of 1,047 patients that have been infected with HIV, 120 doctors, and 8 heads of services that provide the HIV treatment. And now on behalf of 1,047 people living with HIV, 120 experts and 8 heads of HIV service, also the members of our team, were doctors of various specialties, epidemiologists, psychologists, and other experts, those who work in social field with our patients. This is our team that have taken part in the trial, and I think we represent a very interesting component of the reality. So what did we have in order to get an objective picture? So what stop our patient from taking the drugs? Certainly we can ask directly our patients and we can ask them what are those risks, what are the obstacles that prevent them from being compliant. We can ask experts what are the reasons based on their practice, their experience, and then compare their answers. We use both opportunities, and that's what we had. So talking about the risks, the first risk that I would like to show to you is possibility to take care independently of their health. So where our respondent says, I have no chance to take care of my health, or I have all opportunities to take care of my health. So when we see 5 or lower points, it certainly draws our attention, because that means it's a direct threat to the compliance that we shape. And we see that about 30% of our respondents from Leningradskaya region, the Tatarstan Republic, and Azerbaijan, so 30% of the patients said, I have no chance to take care of my health in an independent mode. In other regions, the picture was more favorable. So first risk was self-evaluation of ability to take care of themselves. The second is ability. Are you ready to take care of yourselves? Again, we see 5 or low points have been shown in a number of regions. We see in Azerbaijan about 30% of the patients responded to these very easy questions that they are not able to take care of my health, and certainly we should focus our attention on it and understand why, what happens in this field. And talking about particular risk, what can stop you from taking care of yourself? So as for Leningrad region, Tatarstan, and neighboring Republic of Belarus showed that about 50% of patients understand that there are certain obstacles that prevent them from from having regular treatment. Then we have regions where about 30% of the regions, such as Kyrgyzia, Uzbekistan, Armenia, and do not understand those risks. So what risks are we talking about? First of all, it's work environment and work. So situation when our patients have no time to visit regularly their doctors, treating doctors. So we see that Uzbekistan has the most adverse situation. Then it's followed by Tatarstan, Belarus, Armenia, and Azerbaijan. And in Tajikistan, risks associated with work are not very significant, even though there are some other risks that are relevant there. So for each region we studied, we could develop a profile. For example, a picture for Leningradskaya Oblast. So less than 5% are already to visit regular doctors and take antiviral agents. About 35% say they do not have an opportunity to take care of their treat. And the biggest factor is office work that prevents them from having sustainable treatment. In Tajikistan, we see that most of patients are ready to pay visits to the doctors. They are ready to take care of themselves. But as for work as a risk, it is not among the significant factors. But here there is another risk. It's our family and the nearest environment. And also material aspect is among other risks. Therefore, we have to take into account the risks and act accordingly. As we say, our patients see one risks, and our experts see other risks. So let's have a look at the Republic of Tatarstan and see what's going on there. We see the green column is represent patients. So we said work was the number one risk. As for experts, they do not mention work among the risks. Here we have a very tentative aspect as circumstances, whatever it means. So sometimes they just forget. So 0, it is health condition. In our patient, among our patients, they believe it influences more to compliance. But the experts believe that character features of patients is what influence their compliance. Again, lockdown, patients say it was a big factor. Sometimes it could be an emotional factor. For example, lack of medications could be associated as an emotional risk. So that shall be specified. So those were risks. Again, let's talk about resources because let's think what can help us to improve the situation. So sonogenic behavior, a very nice term. We talk about healthy lifestyle and so on. So sonogenic behavior. So we ask our respondents, I'm talking about 147 patients living with HIV, what do you do in order to take care of your health? And when we hear, I take antiretroviral agents, that sounds good. It's a good resource. So let's have a look at the share of content that is linked to antiretroviral therapy. So we see very good performance in the Republic of Tajikistan, Armenia, Azerbaijan show good figures. But what about Leningradsky region, Tatarstan, Belarus, and Kyrgyzstan? Show worse performance. So they take antiretroviral therapy, but as for awareness, here the level is much lower. So that's a very good indicator that allow us to take appropriate actions. As for our experts, we asked them, do you have enough resources to improve compliance? And these are the results. So, experts in Azerbaijan, Armenia, and Tajikistan evaluate very well their resources. As for Tajikistan, they also have good figures. As for Leningradsky region, Tatarstan, Belarus, and Kyrgyzstan, so they have different figures. So, dear colleagues, that's the picture we had. So those are the facts we got out of our study. But at the same time, we had to find an indicator, something that would make it possible to focus the compliance in future. So we've been looking for such an indicator and we finally found it. So let's have a look at the indicators as self-assessment of health in points, ability to take care of themselves, readiness to take care of themselves, to pay visits to doctors and take antiretroviral agents. So, comparing those indicators and thanks to the efforts of our expert in medical cybernetics, we found the following factors. So the basic indicator is self-assessment of health. So if we have a high point in this regard, we can expect that the patient will be ready to take care of themselves, visit his or her doctor, and take antiretroviral therapeutical agents. So, making a conclusion of what we have found in our study, we can see that risks to be non-compliant have some regional specifics. They need to be monitored. Today it could be one risk, and in 1 month it could be another risk, and they certainly have to be eradicated. So starting then it will allow us to switch from making statistics to taking some certain measures, preventive measures. And modern technologies to work with risks will be efficient. As for low compliance, the risks are seen differently by patients and medical experts. So we have to find a compromise, a consensus in this regard. As for evaluation by patients of his or her health, make it possible to focus how ready he will be to visit doctors and take antiretroviral agents. And one of the indicators of the efficacy to shape compliance is regular visits to the doctor and antiretroviral therapy, which gives the highest results. So we can ask a very easy question: how do you take care of your health? And then you get various answers, but very seldom retroviral agents are mentioned. Thank you very much for your attention. This is our team. We are ready to publish the results of our work, and in the third issue of the journal Epidemiology, we hope to publish the main findings of our study, and we hope that this work will be continued in future. Thank you very much, dear colleagues, for your attention. Well, dear Valentina, thank you very much indeed. You covered very important aspects, and it was very interesting to see different perspectives of the patient and the medical expert. So it is very important for us to see what our programs are aimed at. So these findings are extremely important. Healthy lifestyle is important. Prevention is the key of success. But nevertheless, in order to provide comprehensive solution, it is important that patients remember about antiretroviral therapy. Thank you very much again. Now I would like to pass floor to Inora Akhmatsova, who is the head of Ministry of Health of the Republic of Kyrgyzstan. She will be talking about the Russian program of technical help to fight the HIV and AIDS in Kyrgyzstan. I know the floor is yours. Hello, dear colleagues, dear participants of our international conference, Epidemiological Well-being. May I have my slides on screen, please? Well, as for the Republic of Kyrgyzstan, we have been working closely in the field of prevention of HIV for more than 30 years, and certainly within this period, the project, the original project that has been carried out by UNAIDS started to be rolled out in 2013. Today, in the Republic of Kyrgyzstan, we are carrying out the stage 3 of this project. So it had a number of specifics in its implementation that included the responsibility of Ministry of Health and Social Development in developing regulations and methodology, training of specialists in implementations, and report at the regional and national reporting at the regional and national level. As of the beginning of 2021, in Kyrgyzstan, there have been registered 10,343 cases of HIV, 9,770 count for the citizens of Kyrgyzstan, and 473 are among foreigners. 63% are men, and the rest are women. Out of all registered cases, 2,500 people died. By the end of 2020, the number of people living with HIV accounted for 10,000, and 70.5% have been diagnosed. Among the citizens of Kyrgyzstan, about 30% of people living with HIV do not know about their status, and 63% of them of patients get antiretroviral therapy out of those who are aware of their status. The gap between those who know their status and not is 37%. Most of those who do not get any treatment are people who refuse to take any treatment in medical institutions due to stigma, social stigma, or discrimination, or due to the fact that they are migrants. Most of people who do not get treatment are among key groups such as Lewin, virus suppression is achieved due to the efforts and high compliance, introduction of new schemes with the use of dolutegravir. In the country, the HIV epidemic is at a concentrated stage with a higher prevalence high prevalence among the key group of patients, such as people living with HIV, men having sex with men, and so on. And prevalence among people living taking drugs injected rain is 25,000 people. 6.6 percent account for men having sex with men, and 2% are among sex workers out of 7,100 people. 11.3% account for those who are in jails out of, and that figure reached almost to 9,000 people. In recent years, we have seen the reduction of HIV detection among certain groups of population. That is due to the better control of drug circulation in the country. The increase among men having sex with men is associated with sex transmission. On this slide, you see that in our country there is an increase of transmission of HIV sexually, and a higher share of women that have HIV. It's the high diagram we can see The reduction of parenteral way of transmission through injection drug consumption from 67% out of annual detection amount in 2011 to 7.2% in 2020. Also, there is an increase of HIV infections among women. If you look at the low diagram, you can see the increase in of HIV in women starting from 2% up to 40% in the recent years. This trend reflects this current situation that HIV is spreading faster among the overall population, and as the recent studies show, we have to increase information awareness to prevent HIV in our republic. Cooperation with the Russian Federation is based on epidemiological situation and is aimed at prevention and on-time detection of people living with HIV. Also, we aim at introduction of new ways of control, contemporary methods of prevention of HIV among immigrants, and wide application with the use of experts from various fields, and also high compliance, therapy compliance, higher control of HIV in medical organization, and also carrying out joint research and trials in order to understand better the disease. In our country, at the moment, we introduce self-testing kits together with the Russian Federation. We have been developing regulations to change the protocol of testing, HIV testing, according to the latest recommendations of WHO. In the country today, we have a high number of express testing kits, and this work is supported at the level of medical organizations that deal with more people with symptoms of HIV in order to provide on-time response and high-quality epidemiological control. We cooperate to assess the HIV situation among especially new patients. This measure makes it possible to carry out work in order to detect the origin of the infection. At the same time, by 2020, we have been planning to study by behavior of transgenders and immigrants. Previously, it was not among our prevalence groups, but by the results of this study, we will carry out events on HIV among immigrants that account for more than 1 million people of population, so which is 15% of the population, of overall population. Together, we have developed an instruction to deliver antiretroviral agents to medical institutions and the model of antiretroviral therapy. These instructions are practical tools for all medical experts, all medical institutions in Kyrgyzstan, and non-commercial organizations. Thanks to the efforts aimed on prevention among pregnant women, we got higher results on transmission of HIV from mother to child. More than 95% of HIV pregnant women get antiretroviral therapy. As a result, vertical transmission has reduced in Kyrgyzstan from 7% that was seen in 2009 to 2% in 2020. to diagnose HIV in newborns born by HIV-positive women, as we have developed diagnostics of HIV that is carried out in the first 48 hours after the birth. We have trained more than 1,000 volunteers that work in the country in order to prevent HIV and prevent transition of HIV from women to
сел в нашей
And it allowed us to cover 72% of villages in Kyrgyzstan. We have 12 multidisciplinary teams, and thanks to that, we managed to increase the coverage 2.5 times. And the number of clients increased from 42% in 2015 to 72% of the number of registered people in 2021. The coverage of ERT therapy grew by 3.6 times from 250 people in 2013 to 1,478 people in 2021. To prevent COVID-19 infection, for the clients of this program, information materials were distributed in all multidisciplinary teams. To retain people on therapy, ARV drugs were delivered for the time of 3 months for all the patients with HIV. And to preserve compliance, online algorithm was developed, and food sets were given to the clients of multidisciplinary team that needed it. And this model of multidisciplinary approach became the basis of the order approved by the Minister of Healthcare on decentralization of services at the level of primary medical sanitary assistance. And the School of Patients for PLHIV patients was transferred to audio format, and it was placed in social networks and mobile applications for PLHIV and key groups of population that is especially important during COVID-19 pandemic. The establishment of youth center, that was already pointed out, had a goal to help young people who faced the problems of growing up, children and teenagers. And it was important for them because it was a place where they could stay in touch, share with their problems, and of course get the consultation services of psychologists and other specialists. When cooperating within the project, a manual on infectious control was reviewed. It was explained to all medical officers for the purposes of monitoring and its daily fulfillment. As it was said, within the project, in the end of 2019 and in the first quarter of 2020, 2 sets of sterilization equipment were bought. They included 6 items of equipment and furniture for equipping model centralized centers. National Center in Bishkek was equipped with this equipment, and a large center in the city of Osh was equipped as well. The centers will use the equipment as training and demonstration material for the purposes of infectious control in Kyrgyzstan. And within the program of technical assistance, actually we already mentioned that a lot of mobile vehicles were supplied, and now they help us cover regions that are difficult to reach. Kyrgyzstan has small population, and we also have remote regions, remote locations, and these mobile clinics became the main points of mass testing, not only in cities, but also in villages of Kyrgyzstan. The work of these mobile clinics actually helps us to fight fear and stigmatization for PL-HIV. For today, mobile clinics have examined 218,000 people and 78,000 people were tested for HIV. And mobile clinic works not only for detecting and testing of HIV and hepatitis. During the pandemic, these mobile clinics were used also for the problem of immunoprophylaxis, for immunization in the context of COVID-19 pandemic. And of course, Kyrgyzstan also participates in all studies. So we have federal institution, and actually we cooperate with Russian Watchdog for Consumer Protection, and the research includes prevention of HIV strains dissemination that are resistant to ART therapy, formation of compliance of patients, complex analysis of medical, biological, and social demographic factors of TB risk in HIV patients. And we also participate in joint research. We conduct research together with Vector Center. This is molecular genetic monitoring of HIV dissemination in EECA countries, the selection of genetic variants of HIV-1 to be included into the collection of HIV strains. And today, we can hear a lot about the results from these trials where Kyrgyzstan participated, and other trials are going to be concluded. And in conclusion, speaking about the participation of Kyrgyzstan in our project, I'd like to point out that the main developments of the project are included into the plan of actions of Kyrgyzstan for preventing HIV for 2017-2021. The main developments of the project are included in a number of orders of the Minister of Healthcare. The Minister of Healthcare today is also a Minister of Social Development, and it takes measures on institutionalization of programs. So, out of innovative programs, these programs are transformed into routine and stable ones. And we have seen the beginning of the collection of funds from state budgetary fund to finance the work of social sphere. Within this project, training programs have been developed as well as SOPs and standards. And today, they can be used even in other countries. They are applied for training doctors and medical officers. They are also used in medical colleges and medical universities in our country. And during this time, the implementation of this project enabled us to extend the coverage, to improve the quality of diagnostics, to improve the quality of life for people living with HIV, to improve compliance and decrease stigmatization of key population groups in Kyrgyzstan. And using this opportunity today, I would like to thank our project, the Russian Federation, UNAIDS, Speeding for Connection Foundation and every employee that works within this project. Indeed, we have managed to resolve a lot of issues for sanitary epidemiological well-being in Kyrgyzstan. Thank you. I know, thank you for your presentation. The results are remarkable indeed. And I'd like to point out that they cannot be reached alone. So we really need collective work. We need cooperation and will to victory on behalf of the government of Kyrgyzstan and on behalf of the Russian Federation government. And you already mentioned the efforts taken by UNAIDS and, of course, Speeding for Connection Foundation. This is our joint work, and it's especially important in this difficult time. I'd like to emphasize once again that COVID-19 pandemic has shown us, well, could we actually think in the beginning of last year that governments of all countries will unite to solve common problems? Because we saw opposite trends. We saw that some countries became more egoistic, and still to preserve their stance, they are continuing their policy of isolation. So it's important that the representatives of the countries present in this room show a different example, and we need to continue following this way, because together we're strong. So now, I would like to give the floor to our next speaker and see the results that can be reached in another country. This is the Republic of Armenia. Marina Astan, coordinator of mobile clinic projects of the National Center of Infectious Diseases of the Minister of Healthcare of Armenia. And she will speak about the way we can resolve these problems. Marina, the floor is yours. Thank you. Distinguished colleagues, first of all, I'd like to say a few words about the epidemic of HIV in Armenia. In late 2020, in Armenia, 4,154 cases of HIV infections were registered among Armenian citizens. And the estimated number of people with HIV in Armenia is 4,850. Armenia is a country with low dissemination of HIV. It is only 0.2% among grown-ups. That is several times below the average indicator of Eastern Europe and Central Asia. And from the beginning of the epidemic, 931 deaths among HIV patients have been registered. Over the last few years, the epidemic of HIV in Armenia has acquired specific trends. For the last 10 years, among the registered cases, we've seen high share of heterosexual way of transmission. It is 80%. It has been so over the last 5 years. Another important feature of HIV pandemic in Armenia had experience of risky behavior outside Armenia, and most likely they were infected there. That is 54% of all cases we have had over the last 10 years, and if we add here their sexual partners, then the overall migration factor will reach 65%. Since 2013, we have had Russian program of assistance in Armenia for people with HIV and AIDS. The main partners are Russian Watchdog for Consumer Protection, UNAIDS, and AIDS InfoShare Foundation. The main areas of the program are as follows: strengthening of contravention to HIV among work migrants and other vulnerable groups, strengthening system of prevention and control over HIV in women and children, strengthening potential of experts in HIV, improvement of complex epidemiological surveillance on HIV and research. One area of the Russian program for helping us fight HIV and AIDS includes projects for preventing HIV among work migrants and their partners that is done with the support of AIDS Infectious Foundation and UNAIDS. Somehow I cannot change the slide. Within these projects, we have seen various events that are aimed at increasing the access to testing and consultation for HIV, early diagnostics of HIV with subsequent treatment and care, migrants, their partners, representatives of communities in mobile clinics and village outpatient facilities get complex set of services include information campaign on HIV/AIDS, HIV testing, hepatitis B and C. Today, in village outpatient facilities, these services are rendered, supported by UNAIDS, and in mobile clinics. Medical services are provided with the support of AIDS Infectious Foundation. Model clinics that were given to Armenia by the Russian Federation make significant contribution to testing coverage of migrants and their partners. The first set was received in 2014 during the 4th Moscow conference. The second one was received in 2016 within the 5th conference, and the third one was received in 2019. In mobile clinics, apart from testing and consultation for HIV, hepatitis, and syphilis, ultrasound study can be done and medical consultation is given. On the whole, till 2021, we've seen about 70,000 HIV, hepatitis, and sexually transmitted diseases tests in work migrants, their partners, and representatives of communities in mobile clinics and village outpatient facilities. HIV diagnosed people were registered, and subsequently, specialized treatment was given to them. In 2020, from the 1st of July to the 31st of December, 6,121 tests on HIV was done, as well as tests for hepatitis and sexually transmitted diseases among migrants, their partners, and community representatives in mobile clinics and village outpatient facilities. These mobile clinics started work in July 2020. The programs were adapted due to the difficult epidemiological situation. Such villages were selected where the epidemiological situation was quite calm, and specific manuals were developed on infectious control for people who worked in mobile clinics and beneficiaries. They were adapted to new realia. In 2020, 6 cases of HIV were found. 70 beneficiaries had positive result on rapid test for diagnostics of hepatitis B, 77 beneficiaries, hepatitis C, and 17 beneficiaries had positive result on rapid test for syphilis diagnostics. Patients were referred to the necessary experts for further examination and treatment. Thanks to the implementation of the project for migrants, we've seen increased access to HIV tests, the diagnostics, and timely treatment. HIV tests in communities participating in the projects becomes available. Negative attitude to HIV tests is overcome. Stigmatization and discrimination to patients with HIV is decreased. We see formation of safe behavior skills and a habit of testing among seasonal work migrants. In the years 2013-2020, about 350 villages and towns participated in this project, and more than 70,000 labor migrants, their partners, and community representatives have been covered. Within the project, we see COVID-19 tests that are done with rapid test systems on immunoglobulin IMG, on the basis of mobile treatment and diagnostics complex. The employees of Checkpoint were tested, as well as the employees of National Center of Infectious Diseases are regularly tested for COVID-19. I'd like to point out that mobile medical clinics during this time use laboratory potential, and they were actively involved in fighting coronavirus infection. In mobile clinics, diagnostics of coronavirus infection was done with PCR method. In mobile clinics, we've seen tests for coronavirus infection. These tests were done for the employees of the Committee of State Profit under the government of Armenian Republic. Rapid test systems for the presence of immunoglobulin IgG was done during the second wave of coronavirus infection in October in mobile clinics. Once again, outpatient facility admitted patients with coronavirus. Mobile clinics are also used for various public events that provide for popularization of HIV tests in our community, especially among young people. Change of stereotypes on HIV tests, so people would understand that HIV tests are important for their health and for prevention of infectious transmission. Public events are conducted in provinces and in the capital. During these events, people who want it receive an opportunity to get free anonymous tests on HIV, hepatitis B, C, and syphilis using express testing method within 15 to 20 minutes, and they can learn what their status is. Over the whole time of these projects, in 13 Armenian cities, more than 75 public events have been conducted. More than 7,000 people have been examined and learned their HIV status. Armenia is a small country, and this is a good indicator for us. In 2020, due to the lockdown, all public events, unfortunately, were postponed to 2021. Within the Russian program of assistance supported by UNAIDS in 6 Armenian regions, we have women community. This community strives for decreasing the vulnerability of women to HIV and increasing their motivation to be tested on HIV. Since 2014, more than 4,500 beneficiaries participated in the meetings of this community. And we also have resource centers. In 25 villages and towns of 7 Armenian regions, the centers continued their work on preventing HIV among teenagers and adolescents using various information technologies. Since 2014 till 2020, about 5,000 teenagers had visited the resource centers. In 25 villages and towns, workshops were conducted. The method that was used was peer-to-peer method, and 500 employees were trained. In 2020, all the works were adapted for the new reality. In 2020, a seminar for 25 representatives of the self-governance organs was conducted. These are spheres of healthcare and social well-being. To improve the qualification of medical personnel in terms of HIV and AIDS, since 2010, the National Healthcare Institute has used training course devoted to HIV infection on the basis of National Center of Infectious Diseases. This training course is aimed at developing the potential of medical officers on the issue of prevention and treatment of HIV. In 2017-2020, this training course has been supported by UNAIDS within the Russian Program of Assistance. In 2017, online course was implemented. It was supported by UNAIDS within Russian Program of Assistance. And within the Russian Program of Assistance, we have seen the implementation of joint research, and in spite of difficult epidemiological situation in the country due to coronavirus, we see a continuation of joint research. This research was described by Zoya Konstantinovna Suvorova, so I'm not going to dwell upon it. And now I would like to move on to conclusions. I know that we actually have run out of time. So summarizing all the enumerated issues, we can conclude the following. The Russian Program of Assistance to fight HIV, AIDS, and Armenia is in line with the national strategy on counteracting HIV epidemic in the country. And it is still relevant, and these events are not covered by our financial sources. It is promising from the research standpoint, speaking about the study of important areas of HIV. It is focused on most vulnerable population groups in the country. These are migrants and their partners due to the main trends of HIV epidemic development and overall epidemiological space and flows of labor migration in this region as a whole and between our countries in particular. It has a systemic approach. It takes into account modern achievements, methods, and technologies that are used today to fight HIV epidemic. And it contributes to achieving the goals 90-90-90 and fulfillment of other national and international obligations. Thank you. Thanks a lot. It was a very complex presentation indeed. It was very interesting and important. I hope that we will continue our joint work to reach overall epidemiological well-being for the benefit of health of our people. Unfortunately, now I have to conclude this session because, well, we started it a bit late, and actually the organizers are saying that I should not torture the participants. And for us to remain healthy, it's also important to remember about our meals. So now I would like to invite all of you to have lunch outside. You will get it. So yes, there's food outside. So thank you once again for your very substantial and important presentations. And we will continue our joint work. And I'm sure that if someone has any questions, you will manage to ask your questions during the lunch. And after lunch, of course, we will continue discussing important topics on other parallel sessions. Thank you once again. Wish you all the best. And I would like to thank the organizers of this conference and the Federal Service on actually Russian Watchdog for Consumer Protection and Federal Vigilance Service for Human Well-being, its InfoShare Foundation, and all the participants and speakers. Thank you.
Может, пересядет? Давайте вот сюда поближе, да начнем, что нам время, время дорого. Мы с вами самые дисциплинированные. Нет, я болею.
Он директор нашего института молекулярной биологии.
Давайте начнем, наверное, время.
Well, let's get started. I suggest that we do not waste time. If we have more participants, we certainly will be very glad to greet them. Well, good afternoon, dear colleagues. So we have run out of time. And I suggest that we get started. Our session was on the international cooperation to fight spread of feral herd infections. Well, dear colleagues, you certainly do know that infections have no borders. And first of all, that regards to feral herd infections such as plague and other dangerous infections, tularemia, fever, Crimea hemorrhagical fever, and so on. So this question is very relevant, and I would like to pass the floor to our first speaker, director of the Scientific Research Institute of Irkutsk and the Far East region, Balakhonov Sergey. Good afternoon. Good afternoon, dear participants, dear colleagues. While my presentation is being loaded, I would like to say thank you for the invitation at such important conference, and will say a few words that cooperation to provide epidemiological safety and well-being between Russia and Mongolia have a very rich history. And it marks by a number of events. I certainly would not stop on all of them, but certainly I have to mention that this year, next slide please. This year we celebrate the 90th anniversary of Russian and Mongolian cooperation on prevention of plague. In 1931, the first laboratory on long-term cooperation between the USSR and Mongolia was established in the city of Ulaanbaatar and transferred to the Ministry of Health of Mongolia. And at the same time, a large team of Russian plague experts started to work in Mongolia, headed by Mr. Berlin. And they started to provide trainings to Mongolian doctors in order to provide sufficient monitoring in areas infected with plague. They started to train new specialists, and this work has been continuous for 90 years, including the World War II. There was a short break in 1991 that ended in 2016, and unfortunately that break led obstacles to provide epidemiological safety that I'm going to talk about. Next slide, please. So what is the importance of this international cooperation to provide epidemiological safety between Russia and Mongolia? Well, on this slide, we see that we actually have a joint issue we have to address together. I'm talking about plague areas in Mongolia that, as you see, are quite frequent. In total, there are 49 plague sites that are located in various geographical sites. And moreover, we understand that we have a very long border between Russia and Mongolia. There are lots of transition points. And besides, there is migration of animals in between the countries, as well as lack of visa requirements. Besides, we have close cultural ties with this between each other, which lead to higher risks in plague distribution. As you see, the north parts highlights the plague areas in Russia. One is located near Lake Baikal, and on the left we see two more sites in the mountain regions that actually cause lots of problems to our state in Russia, in Central Asiatic zone. Next slide, please. So, as for development of the joint activities in Mongolia, it follows the following scheme. At that time, certainly a number of Soviet experts were working in Mongolia. There was a center of nosology infections, and it has 14 branches in areas with frequent outbreaks of plague. But given the intensity and the high distribution of plague in the country, certainly it always needs more qualified personnel. Mongolia needs support that it gets from Russia. In 30 years, we have prepared statistics that shows outbreaks of plagues in 30 years, in the last 30 years, and we see that in 13 districts and overall there are 21 districts or counties in Mongolia. They account for 60% of Mongolian territory, and every year they have complications with plague. As for dynamics of prevalence of plague, looks as follows. Even though starting from the year of 2000 there have been seen some stabilization, at least it is treated successfully, so the incidence is limited by very few cases. Still, we see that mortality rate is more than 42%, which means that this is a very severe problem, as we understand that if infection goes to the next level of spread, it leads to other mechanisms of dissemination that complicates the measures that have to be taken. In 2012, for the first time on the border with Russia, we have detected the virus on the border of Russian Mongolia, and we detected high virulent strain of plague microbe, which was absolutely surprising to us because previously we had never found a strain like that on the territory of both Russia and Mongolia. So we understood that the potential of this outbreak could be very high and there was a risk to infecting other people, and that was proved in 2014, 15 and 17. There were 3 cases of plague in Russia among local people after they went hunting illegally, and they got infection through a contact with animals. Each case was detected quite fast. Patients were isolated, and a number of measures were taken in order to prevent the infection into entrepreneur's phase. Can we go back on the previous slide? On this slide, I also want to draw your attention to the fact that before 1990, this territory was under very strict monitoring, and we isolated more than 50 strains of plague. But they all were non-virulent strains. Never before 2012, we did not get high virulent strains. Therefore, together with the Mongolian Ministry of Health, we started to develop a program on reducing plague spread that was included in the decree of the Russian government by 2016, and the certain mechanism was launched in order to minimize the said risks. The main directions of our activities are shown on slide. So the number one goal was to prevent a distribution or spread of plague in the Russian Federation. So what will we going to do to increase our prevention measures? high level of anti-epidemic readiness both in Russia and Mongolia, irradiation of plague sites, materials and financial support to Mongolia, and improvement of international cooperations to reduce risks of plague infection. So next slide, which I really want to show you, shows our joint cooperation. So first of all, we did joint expeditions to monitor plague sites, and within 3 years we carried out a very thorough work. Joined teams of experts from Russia and Mongolia were working on the border between Mongolia and Russia, carrying out a number of actions to evaluate properly the current situation. In 2020, unfortunately, that work had to be stopped due to the outbreak of COVID-19, as the border between Mongolia and Russia was officially closed for the set period during lockdown. Here you see areas where we conducted our studies. So we worked along the Russian border, and the distance of our work covered 100 kilometers. So you see the number of sectors that were evaluated in 2020. Here you can see data provided by our Mongolian colleagues of work that they did on their own. As for methodology, we collected field material, including remains of dead animals that died of from plague. So we did visual monitoring, collected dead bodies of animals. So our experts would monitor a site on car by car, and they would kill infected animals and would collect some parasites. Yes, during the studies we used all the available tools. The set results we would carry on the electronic cards and made geographical positioning in order to understand the release of the plague microbe when we had positive PCR and immunochromatography tests. As for lab tests, we did it as follows. All field materials that had been collected would undergo PCR test and immunochromatographical tests. When we got positive results, they would would undergo bacteriological test, and depending on the result, we would take the appropriate actions. As for efficacy of those express tests, and the random bacteriological test was more than 90%. So this is a very good solution for field screening. First year we worked in camps, and next year we used a designated lab that has been shown on this conference previously. Overall, within 4 years, within the 4 years of monitoring, we isolated 99 streams of strain of high virulent subtype that led to outbreak in Mongolia and Russia. All those strains, apart from one, was obtained from gray ferrets. And I should say that the sites of the strains were located in the area of 1,963 square kilometers along the border with the Russian Federation. And they were very close to the border with Kazakhstan and China. The main results of work carried out in 2018-2020 was that there is a circulation of a significant pathogen of plague. It has been detected that in the studied area there is intensive plague spread that is led by Yersinia pestis microbe, and it has been registered in the mountain of Siligin in the southern side, starting from Ulan-Bator to Dorlen-Daba summit. So all these sites were at the height of 22 to 2,800 meters above the sea levels. As for epidemiological situation, the situation was not easy. It was tough. We have been we witnessed group outbreaks in Mongolia with generated shape of plague with 100% of mortality, almost 100%. Therefore, contamination was due to hunting or consumption of raw meat or internal organs that are believed to be medicine in Mongolia. In 2019, we also observed a very interesting fact. There was a high flow of eco-tourists in that part of Mongolia, and not only from Russia, but also from Mongolia, because there are a number of sacred sites here that local people love to visit. And you see here on the picture, there is a monument that is visited frequently by tourists, and we found the infected ferret and isolated 7 strains of plague from this ferret and fleas that were on the dead body. The left picture shows another example. Near to highway Chusky, which is frequently used by Russian tourists and Mongolian tourists as well. So very close to the highway I've been talking about, there have been found a dead ferret that had 2 cultures of the plague microbes. So all those sites are frequently visited by people, and again, epidemiological risks are certainly very high. Overall, if we count all areas west, and we should understand that these strains are distributed throughout that Russian region very fast. So simultaneous circulations of virulent strain was at a high level. So we have registered 51 sites of plague outbreaks, 51 cases of plague outbreak. So, and here you see some information on what we do currently. Unfortunately, COVID restricted us from continuing our program, joint program, even though we do understand high importance of the project. This year, again, due to our solid experience of joint work, as we had on-time reports on each case that pointed to possible plague risk, we were able to act to respond appropriately. Overall, we had 19 suspicious cases of plague, and but we only in the Mongolian region. The next component is better readiness to fight the spread. We have provided trainings of Mongolian specialists. In particular, we conducted 72-hour seminars. We have prepared, and one of the seminars was held in Ulaanbaatar and included training of 21 specialists. Certainly, trainings are extremely important. We also did trainings at the sites. For 2 years, we held such trainings both in Russia and Mongolia. We would invite experts from the other country, either Russia or Mongolia. And in 2018, there had been conducted international training. The legend was an outbreak of plague that led to establishment of on-field hospital in order to prevent the spread of the disease. It brought together more than 200 specialists from various fields, including medical experts and so on. And their training showed that Mongolian colleagues are fully ready to counterpart this disease. And when, in fact, they had an outbreak on the border with Russia, when 2 people died, they followed the algorithms that we practiced during the international training. As for material and financial support, we on the regular basis, we provide diagnostic tools to our Mongolian colleagues, including testing kits, lab equipment, disinfection equipment. We provided a mobile laboratory. And in November 2020, despite the border was closed, we transferred, we provided Mongolian colleagues with this mobile lab complex, and they feel very thankful for that, because it really helps to optimize their work. In the near future, if there are no reasons to believe that situation is going to improve with the plague, since the main focus of the medical community today is on COVID, and especially given the high density of ferret populations in this area, we have every reason to believe that there will be a number of outbreaks of plague in the next years. So we have to be fully ready in order to respond on time. Joint cooperation would be extremely important in future, and works on Russia and Mongolia shall be held simultaneously. We should remember that plague is an infection that doesn't allow to have any compromise with it. So surprises as we had in 2014, 15, and 16 shall be prevented in future. We work in accordance with the decree of the government of Russia, and the conclusions are quite similar to what I've been talking about. Certainly, epidemiological situation remains to be tense, both in Mongolia and Russia, especially on the border. In 2021, it shall not be improved. And I did not mention due to the fact that we are limited in time. I forgot to mention one very important project. There was a small local, small area where we found similar strains of plague, and we had a few positive PCR tests. As for the Baikal region area where we took preventive measures, we did not find new strains. Well, and we have to act together to continue our joint cooperation in order to prevent the spread of this infection throughout Russia and Mongolia. Thank you very much for your attention. Thank you, Sergey, for your very relevant and very interesting report. Indeed, the aim to reduce risks of plague complications is extremely relevant both for Russia and Mongolia. And Indian only joint actions, joint efforts will make it possible to fight the infection and reduce risks, as you have shown in your report. Well, thank you very much. Now I would like to give floor to our next speaker, Lilit Avitisyan, the Deputy General Director of the State Non-Commercial Organization of Control and Prophylaxis in the Republic of Armenia. She will be talking about actions on preventing plague in Armenia.
Thank you, distinguished colleagues. I would like to present my presentation. Global warming, natural disasters. Global warming, natural disasters, and international terrorism made us review our approach to epidemiological monitoring of focal diseases, including plague. 95% of Armenian territory is a focus of dangerous infectious diseases. Practical and epidemiological monitoring of natural territories of Armenia was started in the 40s. Today, we have epidemiological vigilance over these diseases. It is aimed at studying difficult phenomena that develop under specific natural and social conditions. To improve epidemiological and epizootic monitoring of plague, we researched the monitoring system. The materials for this research included reporting forms of the National Center for Control and Prevention of Diseases. This work actually was conducted, and we analyzed information from 1975 to 2019. We also analyzed the materials from the archive of the National Center for Disease Control and Prevention. The database was developed in Excel. To process the data, we also used ART software. And we also conducted expeditions, episodic examination, and mapping work. This was monitoring that was conducted in the whole territory of natural plague focus, and Anti-Plague Institute helped us to do so. 76 hectares were mapped, and these routes were mapped on the whole territory of the natural focus in Armenia Republic. Epidemiological and epizootic routes were mapped. and various methods were used, including night trap. On the basis of epizootic data, specific maps were developed. They were developed with GIS 10 use. And we also analyzed the habitats of voles in long-term stationary sites in Pennsylvanian plague focus during 3 years in 2 sites located in northwest and south of this focus. To record the coordinates of every habitat, GPS was used, and we also used laboratory methods such as molecular genetic, bacteriological, and serological ones. We also modeled the foci of plague in Armenia using computer software. In 2016-2018, in the basis of Rose Nikchimi plague, Armenian epidemiologists and zoologists had professional development courses, and in these studies, 2 specialized mobile labs were used. They were used for express diagnostics, and they were provided and entered into operation in accordance with the administrative agreement dated 2016, concluded between Russian Research Anti-Plague Institute, Microbe, and the Ministry of Healthcare of Armenia. In Armenia, on the territory, whose space is about 2.1 million hectares, 2 autonomous foci were specified. This is Transcaucasian Highland vole focus. These are Gyumri, Pre-Savanian, and Zangezura-Karabakh foci. And there is also pre-Araxine gerbil focus. It is located in the north and northwestern part. So the north and northwestern part of this focus is located in Armenia, and part of the territory of both the foci and every mesofoci falls at the territories of neighboring countries. Today, these focus and potentially focused territories are outside episodic monitoring of our system. In pre-Araxine focus, the main carriers of plague include 2 types of gerbils, and specific flea are carriers, Anaphthalmus iranus and Xenophilum conformis. This agent is a gerbil strain, and in Transcaucasian Highland focus, the main carrier of plague is a vole, and the main carriers are flea, Calopsilla casper, and Nosopsilus consimilis. The agent is a specific vole strain. Bacteremia is established in 50% of infected voles. The duration and intensiveness are enough to infect, in both foci. There are accidental carriers of plague that also participate in this epizodia, but they do not play a significant role in maintaining this epizootic process. Epidemiological manifestations of plague in the territory of this focus have been registered since 1958. So 1958, 1969, and 1975, there were 3 such cases. In 2017-2018, episodic study of Prisylvanian focus made it possible to catch a lot of rodents, and 1,600 flea and 7,000 mites were collected from the fur of these rodents. And among the samples gathered in 2017-2019 with the PCR method, 460 rodents have been studied. And we also studied 5,689 ectoparasite. There was one biosample, 6 nests, and the total number of molecular genetic tests, PCR, was 443. 166 rodents were studied with serological method, and the total number of serological studies was 180. The number of the main carriers of plague microbe, gerbil and vole, was low and middle. In Prisylvanian mesophocus, that is 7.43 animals per hectare. And Zingizura Karabakh mesophocus is a bit more dangerous. The number of voles was 41 animal per hectare, and in some territories it was up to 60 animals per hectare. The number of flea was from 100 to 200 animals per hectare, and the density of gerbils in Priaxan focus was very low. It was not more than 2-3 animals per hectare. Epizodia of plague in Transcaucasian highland focus and pre-Erexine focus in transborder territories as well have not been registered. The last episode of plague was registered in 2008 in Zangezur Karabakh mesophocus. In the territory of Gyumri, Prisylvan and Zangezur Karabakh mesophoci, these are transborder foci, the number of the main carriers of plague microbe is low and medium, and being guided by the data of episodic monitoring, we can suppose that in good environmental conditions only in some sectors of the focus where the density of the main carriers, episodic manifestations of plague are possible, and there are prerequisites for local epizodia. Transcaucasian highland natural focus of plague covers neighboring territories in the neighboring countries, and following the results of focus monitoring, we can suppose that in these territories plague epizodia are not probable. However, some episodic manifestations are possible. These factors show that there is a need to improve episodic monitoring in natural foci in the following areas. It's necessary to select key territories of natural focus that can be a model of this process. To conduct detailed mapping, to extend the range of natural sites that are subject to laboratory plague investigation, to extend sequencing study using sequencer that was provided by Stavropol Research Institute to render methodological support to Armenia, and development of target measures in foci on the basis of the results of foci modeling. Monitoring component of the epidemiological vigilance is done by the National Center for Disease Control and Prevention. Epidemiological monitoring also includes episodic one. The territory of the Republic is divided into 300 sectors. 196 of them are subject to study. Field episodic monitoring in Armenia is conducted by specific groups and epidemiological teams prepared by 4 branches of the National Center, including the Laboratory of Epizooty, Actor Parasite Study and Reference of Lab Center, as well as SHIRVAC and other branches. And in future, we're also planning to open a lab in Lovrinsky branch. Apart from episodic study, in case of epizootium, when the number of rodents and flea is excessive, urgent, specific, non-specific preventive measures are conducted. Over the last 25 years, the equipment of Armenian anti-plague system has become outdated, so this equipment should be renewed in accordance with international standards. After the establishment of contemporary national center, the issue of new anti-plague station was in the agenda. To deploy this subdivision, we received a lot of support from the Russian Federation. So Russia provided Armenia with a mobile set. This is a truck and specific equipment. Thank you. Thanks a lot, Lidit Mikhailovna, for your detailed presentation of the current situation in natural plague foci in Armenian Republic. Today, the situation is calm in Armenia, but still, we should always have epidemiologic vigilance and monitoring over the natural foci of plague. And I'm happy to see that we have active cooperation among our profile institutions of the Russian Federation and Armenian Republic. This is a very important era, provision of epidemiological well-being in terms of plague. Thank you. And according to our agenda, we're going to have presentation of Niels Christian Stenseth from Oslo University from Norway. So, do we have connection? Yes. Niels is connected. Mr. Niels, the floor is yours.
Can you see my screen now? Can you see my screen?
Мы вас слышим и видим.
We can see you and we can hear you. Yes, we can hear you. Yes, and we can see the presentation.
Very good. Thank you very much for the invitation and the introduction. Dear colleagues, scientists, ladies and gentlemen, I'm very happy to be invited, and I'm very happy to listen to the presentations that have been preceding me. I'm going to speak on the partly plague, but really what we can learn from previous plague pandemics in the current COVID-19. Something wrong here now? I don't get my cursor. Yeah, I don't get. Sorry. Yeah, here it is. I'm terribly sorry about the technical things. I'm a professor of ecology and evolution at the University of Oslo, and I'm the past and founding chair of Center for Ecological and Evolutionary Synthesis, where we have done a lot of zoonotic work, not the least on plague. I worked on plague for many years now, and plague, as you know, that is a disease of today, as we heard from Balakono, but also a disease that changed the history, human history. And as we have heard in previous presentation, the two previous presentations, this is indeed a disease of today. This is the WHO statistics where you have active plague outbreak and plague foci around the world. And as you also remember, there was a huge plague outbreak in Madagascar a few years back. I started working on plague some 20 years ago. It started in Kazakhstan, analyzing what I call a gold mine of data from the Soviet Union period, monitoring data that you did all over the previous Soviet Union where you had plague activities. Dry areas, higher altitude, etc. I then got involved, and I continue to be heavily involved in China, with plague work in China. As a matter of fact, we did a paper study on the border between China and Kazakhstan, where we studied the temporal variation in genotypes and population sizes, both of the host population, the vector, and the evolution of the bacteria. Also been working in Mongolia, currently analyzing Mongolian data together with Chinese data on gerbils, on marmot, and also been interacting with Russia. I started off studying plague as an ecological system out in nature, out in wildlife. But I've, in the recent several years, also been interested in how nature and human population are interlinked. And a key focus in my work has been to study the effect of climate variation, which plays a very key role in the dynamics both in nature and regarding spillover to the human population. Indeed, natural catastrophes in the wild lead to catastrophes in the human population. Let me explain a little bit on that. You will have a local outbreak in the wildlife if the host population, say the great gerbil, stays above a certain threshold density for a couple of years over a large area. And if that is followed by a year of unfavorable condition for the host population, great gerbil, for instance a dry year over a huge area, then the wildlife population, the gerbil population crashes, and that is when the bacterium spills over to domestic animal and the human population. That's why I say that when natural catastrophes happen in the wildlife, breakdown of the gerbil population, that can lead to spillover to the human population and then catastrophes like we have seen in the past three big pandemics, plague pandemics. We were fortunate to have a project here at the Center for Ecological and Evolutionary Synthesis focusing on ancient DNA. Actually start studying victims, human victims that for sure had died out of plague, study that from different places around the world in Eurasia, and then see how they link together phylogenetically. Because in 2015, we published a paper based on the Kazakh data that indicated that when there were favorable conditions in Kazakhstan or in Central Asia, favorable in the sense that you had some good years that the host population could build up, the germ population could build up to sufficiently high density, followed by unfavorable conditions so that it crashed, and you had spillover of plague to the human population. So we hypothesized in 2015 that Yersinia pestis, the plague bacterium, had been reintroduced, reinvaded to Europe many times during the medieval period. And here is what we found. In the beginning of the medieval period, that is immediately following the Black Death, the plague came in from northeastern part to Europe. And it probably came in connection with fur traders. This we don't really know, but it's a reasonable hypothesis. In fact, what is known as the land of darkness was sort of the source for the plague. So obviously there has been plague reservoir, which continues to exist, coming into Europe. But if you go later in the medieval period, go to the 1700s, and as you may remember, the last outbreak of the second pandemics in Europe was in Marseille, 1720. During that period, plague bacterium came into Europe several times, but now from the southeastern part, just outside Europe, from Turkey, from Caucasus, etc. So what can we learn from plague fighting over the years when it comes to the current pandemics we are experiencing, the COVID-19? Well, we can learn that hygiene is a key role to control a pandemic. And for plague, this is relevant in connection with human ectoparasite being a vector spreading the bacterium from one human being to another human being. So when hygiene was improved in Europe, that's most likely when plague disappeared and was never able to re-establish itself in Europe. Quarantine, you know, is very effective as avoiding transport across geographic borders. So this is sort of the wisdom that we can take out of the long experience of plague pandemics in the world. Let me now move to the COVID-19 pandemics. I'm running a project being paid out of the Norwegian Research Council, where we try to extract environmental data and try to predict how that affects the COVID-19 pandemics so as to be better prepared for a future pandemic of a zoonotic disease like plague, like COVID-19, I have a dream team of collaborators here from many places in the world, and I have fantastic advisory boards also from several places in the world. You might know some of the people there. We have done a couple of papers already. We published one in PNAS, Proceeding of National Academy of Science, short while ago. And that paper shows that we could control much better the COVID-19 pandemics if the world, the international world, had been much more coordinated. By closing down the biggest airports in the biggest cities around the world for about a couple of months, then we would have had a reduction of COVID-19 incidents by 90%. We are having in second review, another paper now, where we really look at the more detailed structure of the epidemics. We look at the age composition in the country. Some countries have lots of old people. Some countries have lots of young, highly social, have huge social activity, social mobility. And what is the effect of that? Well, we study these kind of models. You don't have to look into that in detail, but this is to show you what I do for a living. Then to the left, we incorporate into this model the demography, the age structure of the population, as well as the social mixing pattern. And we parameterize this and then simulate the situation, so that it changes from the epidemic situation we are currently experiencing toward an epidemic situation that most probably will be a seasonal epidemic, just like we experience in flu. We studied 11 countries all over the globe: China, Japan, South Korea, Spain, UK, France, Germany, Italy, US, Brazil, and South Africa. And we could show that in South Africa, that country is hit harder. It's hit less hard. The epidemics is less severe than it otherwise would have been, because it don't have so many old people. It has much more young people. Whereas Italy are hit very, very seriously because it has a very old population. That paper is coming out in Science Advances in the near future. It's in the process of being accepted now. There are some few details. I will end by a few words about SARS and COVID-19. How the world responded to COVID-19 compared to how it responded to the SARS epidemics. The COVID-19, it was first discovered in China just before New Year, last year. Then it was sequenced in January and published internationally early February. And it was declared a pandemic in March. So WHO responded very fast and in very good cooperation with China. Compared to SARS, the responses were much slower. Whereas it took only a couple of months for the COVID-19 to realize it was going to be a global pandemic. For SARS, it took several months. It was first observed in November 2002, and it was declared pandemic in March, April actually. So we are learning. May I end by talking about how science is very fragmented. This is really how science is operating. We walk along our trenches. We don't talk to each other. We don't read each other's papers. If we go to different conferences. If you go to the same conference, we go to different sessions. We don't interact. Science is very fragmented. Only the specialized fields are interacting. You need to pursue interdisciplinarity. Or we need to pursue interdisciplinarity and internationalization whenever appropriate for the scientific questions being asked. So this is how science should cooperate. We should work within each of the disciplines and come together and exchange wisdom and what we learn from each of the disciplines. Thank you very much for your attention.
Thanks a lot, Mr. Mills. Indeed, this information was very interesting. And I think that it was actually useful for everyone. And there is no doubt that the experience that has been received in fighting the pandemics and epidemics in the past should be analyzed and used in fighting epidemics and pandemics that we will face today.
Well, thank you very much. And now, let me pass the floor to our next speaker. Well, we have Institute from Iran. He will be talking about recurrent infections in eastern region of WHO. So, Mustafa, the floor is yours.
Уважаемые коллеги,
Dear colleagues, unfortunately we have some technical flaws that do not make it possible to link us with the Pasteur Institute. Therefore, let me pass the floor to the next speaker. I would like to give floor to Aida Nizhana from the Republic of Kazakhstan. He will be talking on the importance of the hedgehog as a carrier of plague in the Pribalkharsky plague sites. Alher, the floor is yours. Well, thank you very much, dear colleagues. First of all, I would like to say thank you to organizers for an opportunity to be part of this conference. And let me share with you the results of our pilot project that was carried out in 2016-2018, and the studies were made in Pribalkharsky plague site. The study was carried out within the program Newton-Farabi. Well, a short background for those who do not know what plague is about. It's a very dangerous transmissible disease that is transmitted through fleas. They are carriers of the disease, and the Yersinia pestis is the agent, pathogen agent. It was discovered in 1894. According to WHO, every year witnesses about 2,083 cases of plague infection. Most of them accounts for African countries as well as Madagascar Island. On this slide, you can see the three latest pandemic of plague in 13th and 15th century and 5th, 7th century, the first one, and the modern plague that took place in 1870s, and it was over in 1950s. We all know how drastically our life can change due to pandemic, but imagine what people had to undergo those times. We know that the Black Death took more than half of European lives. As for areas affected by plague, it has been found in most areas of the globe, apart from Australia. Most areas are located in Eurasia, also in North and South Americas, and even in such well-developed countries in the US, there are annual cases of plague with mortal outcomes, with death outcomes. As of today, there have been detected plague microbe in 351 types of mammals. Most of them are rodents, and 280 types of fleas are believed to be carriers of plague. In Kazakhstan, there are seven plague areas that account for 39 to 41% of the overall part of the country. The last plague case in human beings was detected in 2001 to 2003. There were detected 7 cases with 1 lethal outcome. Most of the plague areas have the common transmitter, that is rodent, and 55 carriers and 51 fleas are believed to be transmitters. Thank you. On this slide, you see exotic area in Kazakhstan and classification of affected areas. In the west of the country, you see a violet area where the carrier is a ferret, then Derby is believed to be the carrier, and most of the areas marked in green Account for Gerbia is the main is the main carrier. On this slide, you can see results of the monitoring carried out within 10 years. This data is a bit outdated. At the same time, they give us an idea of what's going on in the country. In green, we see areas that showed positive results, serological results. Red color marks areas with plague microbe, and green and blue, sorry, shows the areas that were covered by the study, by the monitoring. The most active areas are located in southeast area, also mountain part of the country, Big Poktalinsky, and other regions. There is a big question if we talk about plague understanding is to focus, to provide a proper focus of plague. Lots of specialists are trying to provide precise figures, and the current models fail to provide us with precise focused in order to understand when another outbreak shall be expected. At the same time, our Western colleagues in 2004-2014 published a number of trial results where they tried to focus new outbreaks of plague in Pribalkharsky area. This model is quite interesting as it employs main criteria such as a number of carriers, density of its population. At the same time, on practice, practice shows that this model is far from being perfect, and it gives lots of false positive results. At the same time, if you look at the scheme in the right lower corner, when there is a high amount of fleas and large density of rodents, unfortunately, the model fails to give a clear picture. That inspired us to do the following steps. We drew our attention to etiological aspects of carriers, their on-ground activities. In 2013-2013, we used GPS trackers for this type of animal. So this is an international group of scientists, including Australian colleagues and so on. We also had our colleagues from Almaty Research Institute. So within the studies the study we performed, it turned out that as Sandlands is a territory animal, so it lives at certain area which is protected by a male. And with high density of the population, the males prevent other types of animals into getting in the area, which prevents flea spread and therefore spread of infection. With a low density, level of subcontacts goes down and also prevents spread of fleas. For plague, it is favorable to have a medium level density. In such case, animals come to unpopulated areas and there they exchange with parasites that they bring to their own areas. We made a further step and started to think what shall be done in the in-between period. So when a carrier is not found in population for quite a long time, for example, plague can be witnessed within a few years, then there is a break for dozens of years, and then it breaks out again. So we were thinking how the plague microbe lives if there is such a great depression of the number of carriers. And therefore, we drew our attention to secondary carriers that to some extent also have contacts with areas, residence areas of sandlands. So why did we pay attention to them? During the Soviet time, from Soviet literature, we found lots of important information, in particular some patterns that the animals have a very high resistance to the pathogen. They have very high mobility, very high bacterial burden, and in places with outbreak, usually they witnessed a large population of such animals. Also, there is a theory that they don't have an individual area of living and they migrate from place to place. When I mean in particular the type of animals you see on the slide. So why hedgehogs? Well, this hedgehog also live closely to sandlands. It's frequently seen in Central Asia deserts, despite very close contact to sandlands. There have been detected only one case of plague microbe in this animal. In 2016-2018, during the project of evaluation of transportation of small animals as alternative carriers of plague, we paid more attention to the hedgehog populations. Overall, we caught 61 animals, 5 of them Mustela nivalis, and Vermella perigusna, 4, and 4 perigusna. So we used special devices that made it possible to catch the animals. The animals after the catching were placed into a cage for quarantine, and they were observed for a certain amount of time in order to find some signs of disease. After that, when we put on the tracking device of them, there was a requirement for the device to be equal to 5% of weight. Otherwise, animal could act inadequately if it was heavier than 5% of weight. So the animal was given a tracking device we recorded all data on each animal, and after all, the animal was brought back to the area it had been caught and was released. All data on colonies of rodents, description of plants in the area was thoroughly studied and included into the report. We used Excel programs that helped us to do good, precise statistics. In order to have some quantitative data on flea dissemination, we studied a number of literature sources and we took some data as the basis of our study. So, how did we collect ectoparasites? As you see, with manipulation, doing some manipulations with animals, we used a bowl in order to prevent ectoparasites to escape. Then we would collect ectoparasites by aspirator and perform samples in lab. Previously, each unit was marked. Then, during the lab test, we calculated the index of parasite burden. So, how did we track the movement of the animals every day before sunset and before sundown until from 9 p.m. till 6 a.m.? Why did we do it at that time? Because that animals are active at night. We tracked each animal because each of it had a unique frequency. We used triangle method to track each animals, and when we had a visual contact with the animal, we tracked a meter tracked. A person tried to follow the animal in order to define the time the animal would spend in its house. We calculated the time and the number of visits into it. On this slide, you see white points. This is that shows colonies of sandmans, lances. In order to find out how many colonies an animal could visit on its way of movement, we had to provide mapping of each point of residence for each animal. It was not a success every time, as it was difficult to track movement of each animal. Therefore, we modified the so here you can see a distance that shows that is shown in red from A to B. So if the distance was long, it meant that most likely animal would stop somewhere else. Therefore, the radius of coverage of neighboring colonies would be bigger. If the animal was moving from A to B are the points where we recorded the time of our monitoring. So in the second case, if the distance between A and B was not big or the time was not long, the shape or the trajectory of moving was more complicated, as you see on the left part of the slide. So then we analyzed the data. What did we find out? The duration of contact with such points of residence? Well, first of all, we found out that there are two types of spending time, so long-term and short-term. During the day, an animal would stop at such point and would rest until the night. Here we see an average spending time. You see for hedgehog, the short-term stay is quite short, it's 3.1 minutes. And as for the night time, it's quite long, which is logical. Dissemination of flea per visit, what is that? Well, it's a percentage of fleas, and with the index of percentage of block of fleas, so that leaves the animal's body when it comes its residence unit. So together with the use of the literature and analysis of our data, we were able to calculate these figures. During the short-term visits, hedgehog lose more than 1% of the fleas, while other animals live many more. During the daytime when they rest, almost all fleas leave the body and new fleas gets on the body. As for average dissemination, on how many fleas are disseminated by an animal per day, as you see for the hedgehog, it's a very low rate, less than one flea, while with for Nivalis it's about 5 fleas per day, and for the ferret it's about 102 fleas. As for the average amount of points, the visit is about 0.8 for hedgehog and 2.9 for Nivalis. We found out the intensity of contacts, but what if? How objective are these data for disseminators of plague? In order to prove this theory, we took data from archives in our republic, and we got the following figures. So the number of hedgehog was less 1 per Gerbes, and it's even less for the second group of animals. Here you can see the size of home range. First one is the hedgehog auritis, perigusna, and nivalis. As for nivalis, for females, we unfortunately didn't get enough data. On average, for males of our hedgehog auritus, the size of the residence area is about 2.7 square kilometers, and for perigusna it's 4.2 square kilometers for males and 2.5 for females. As for the types of fleas that were found on the animals, again, mostly on this slide we show specific fleas of the Gerbes, except for the flea typical for the hedgehog. As you see, if you talk about quantitative figures, the ferret has the highest parasite burden, and the hedgehog has higher burden than Gerbe. We do not know what are the reasons for that. It could be caused by the size of the animal or some other factors as well. As for the types of mites that we have found on animals, here there is another trend. For the hedgehog, it has the highest burden, microbial burden in terms of mites. On this slide, you can see the number of parasites on the studied animals. In red column, you see mites, and in blue, flea index. Fleas index as for the parasite burden of fleas. So we see that ferrets' burden is much higher compared to gerbies and hedgehog. This curve shows data for the ferret, blue for the whistle, and red for the hedgehog. What is an individual area? It is a certain vessel that would be filled by animal movement at certain time. So we calculated accumulation of colonies visited by a certain animal, and then we calculated this trend, this pattern. You see that the whistle has different pattern of movement. As for conclusion, I would say the following. Given the data, we believe that the hedgehog cannot play a significant role in the flea dissemination and could not be a carrier of plague microbe, even though it could be engaged in the acute outbreaks. At the same time, this type has a limited area of residence that it does not live generally, which means that apart from the polecat, in comparison to polecat that moves a lot, and therefore we can say that it does not have a high risk. But at the same time, given that hedgehogs showed a very high figures in mite parasite burden, we should pay more attention while studying these areas for mite parasites. Well, that's it. Thank you very much for your attention. Well, thank you very much, dear Aidanta, for this fantastic report. Indeed, studying mechanisms of the plague outbreaks and detection and discovering the new information on this disease will stay relevant for in the future. I would like to wish you success in your future work, dear colleagues. We have finished our program. If you have any questions to our speakers, if you would like to provide us with your feedback, we will be very pleased to pass you the floor. Well, as I see, nobody has any questions or comments, so let's conclude our session. Even though our topic sounds as herd infections, today we have focused mainly on the most relevant issue the plague. It was we have shown the relevance of this problem both globally and on the national level. Russia has been cooperated with a number of countries to eliminate the disease, in particular Kazakhstan, Armenia, Mongolia, and it goes without saying that plague outbreaks have no borders. It may happen anywhere, and a large number of outbreak areas points to the fact that we have to act together. We should, and only that will make it possible to provide successful prevention measure. First of all, in trans-border areas. I think this is the most important message of today's session that would be included in the resolution of the conference. Would you agree with that? Okay? In that case, thank you very much. Thank you. Our session is over.